Very good. No, sir. Just I will take a look. Is it mic పెట్టినా తర్వాత Hello. Hello. Good morning, everybody. Okay, పనిచేసే సార్ లైన్లో తీసుకోండి. Sir, some are saying to take femoral vein 8 French access, sir.
Which one?
Femoral vein.
Doesn't matter. I don't take care. The elevator किधर है? Elevator here. Elevator. Plus give me plus please. Plus. बेटा plus give. Plus.
Good morning, everybody. ఒకసారి చెక్ చేసుకోండి. Okay. Good morning, everybody. Today, day 2, we are going for the live case. Now I am going to give the clinical details.
I need pressure line.
Yes, sir.
Okay. Through नहीं.
Artery, sir.
Through. Change the scale, please. Change the scale. Change the scale. Table नहीं है, scale change करो.
1 minute, sir.
Change the scale. I need to see the pH pressure.
They are doing. Good morning, everybody. Patient clinical details. Patient is a 31-year-old female presented with breathlessness on exertion since past 6 months, function class 2. On evaluation found to have chronic rheumatic heart disease, severe mitral stenosis with mild mitral regurgitation, with moderate aortic regurgitation, with mild TR, with moderate pulmonary artery hypertension. Patient is in sinus rhythm with function class 2. Echocardiography wise, severe mitral stenosis with gradients of around P gradient of 33 with mean of 15 mm of Hg, with mitral valve planimetry area around 1.0 centimeter square, with mild mitral regurgitation with moderate PAH. Now we took both venous and arterial access. Patient height is 138 centimeters, so nearly 140 centimeters. As per the Hung's formula, we took a balloon of 23. And echocardiography wise, medial commissure is partially fused with lateral commissure free, with a Wilkins score of 6/16.
Give me the 3 to 1. 3 to 1. 3 to 1. Keep crossing. Rest table, guys. Rest table. Rest table.
Table height, please. Table height. Floor.
Rest table. Show me floor. Good. No, no. Okay, fine. You mean the Mullen. Very good one. Water I can dip here, this one.
Yes.
Then Mullen give, please. Feed the Mullen. Fill middle, please. Holding over, please.
Okay.
Keep it tight. Keep it tight. Tight and straight. And no, what are you doing, my dear? Take that. Give the pigtail, please, because it's a light transition. Give pigtail, please. Pigtail. Okay, give this one. Fine. Not now. Give it. Should do. Should do it. Keep it here. Last. Give pigtail. Pigtail. Nobody is watching us.
Yes, there.
Jaldi put. You should have put wire before. Okay, fine. Come back.
We pass the O32 wire and place in the left innominate vein. And now we are placing the pigtail in the non-coronary sinus of aorta.
Going.
5 French pigtail.
Hold back. Hold wire. Leave it out. And take the...
3 ways.
No.
You have manifold, sir.
So now, what to do? So, I'm there in a
Mic.
mic. I'm there in the innominate and SBC junction and keeping the Mullen sheath assembly. Mullen dilator, Mullen sheath and broken bone needle, and the broken needle attached to a syringe containing contrast. So I can pop it, so some air should come out if the air at least there. No, okay, fine. So pulling down the Mullen, hey, please, that should go out. Just go out. Go out. Take it out. Pulling it down. Okay. I got some bomb there. Go down lateral view. Go to lateral, please. Your LA is too much bulging. Okay. Go dead lateral, 90 lateral. So now, okay, I need to see the sternum, spine, and diaphragm. What is that is coming on the way? इसको बोलो hand को हाथ के ऊपर रखो. Yes. Now give contrast a little bit. So the SB junction now are coming down. So this okay, come to. I am already LA. Inject. Fine. I want to see the frontal view with a good puncture or low puncture, high puncture. Don't know. So good. Puncture is good. So I only pulling out the broken bone needle. I take the pressure now. LA pressure. Give me. Heparin, please, guys. Heparin. कितना? 4.5 gig. 4.5, 4,500. So it in LA now. What is LA pressure? How much?
38/24.
LA mean how much coming mean? LE, so your stenosis is there may not go. Your outer stenosis is there. So LA how much now? LA 30 mean 30. So don't waste time. So I take balloon now.
Moderator. Good morning, Dr. Dash. Yes, sir. Dr. Dr. Sujata is moderating your session, sir. Dr. Sujata is moderating your session. She is from Indus Vizag.
Good morning, sir. So, do you have any tips that there is a lot of any tips, because we have young cardiologists here, subvalvular fusion, at what level you take and what are the steps you would take to avoid an MR?
Dr. Dash. Sir, are you able to hear us, sir? Yeah. See, yeah, at times inflated balloon comes out automatically, spontaneously, but still if you check the gradients or a wall doesn't look to be dilated properly because of the severe subvalvular disease. Uh, uh, what should we do, sir? Whether we should go for a higher inflation or whether leave it?
So with subvalvular fusion, have you undersized your balloon or you have taken the same size? What are the tips to avoid an MR you would suggest to the to the cardiologists here?
Hemodynamic trace. Is there any MR, sir, on echo? MR got increased. V wave appears to be relatively prominent. Yes, sir. Yes, sir. Yes, yes. Can someone show the commissions, short axis view, echo? Yes, sir. Yes. Please put, yeah, please put some color. You see about MR. Yeah, it's mostly commercial MR. Yeah, yeah, fine, 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 sir. Thank you. A good result.
Anybody has questions? Raj will answer.
వీళ్ళిద్దరు జంట, వీళ్ళిద్దరు ఎవరు అనుకుంటున్నారు? కుర్రోళ్ళిద్దరు, మురళీకృష్ణ కొడుకులు, విజయవాడ మురళీకృష్ణ నిజాంస్లో ఉండేవాడు. యాంకరింగ్ అని చెప్పి పంపించా.
అడావడిలో ఓవర్ రేట్లు.
సతీష్ ఓకే కలిసాం.
సెకండ్ లైవ్ తీసేవారు. అదేనా షుగర్ ఆర్ సంథింగ్ ఎల్స్. టీ సెంటర్లో అట్లా ఇటు కూడా దే ఆర్ యూజింగ్ దిస్ ఎవ్రీవేర్. అది ఎక్కువ వీళ్ళు ఒక్క నిమిషం. మణి I request our surgeon, Dr. Satish, to give a memento to moderator of the session, Dr. Sujata.
కెమెరా సిస్టమ్ మన హరి చాలా బాగుంటుంది మేడం. హ్యాండ్ రైటర్
ఇండస్ హాస్పిటల్ మెయిన్ లాబీలో పెట్టండి.
మీరు పెట్టారు కదా ఏంటి అపార్ట్మెంట్లో అలా మీకు కూడా కనిపిస్తుంది.
ఏదో ఎవరో పెట్టారండి, మా బిల్డింగ్ పెట్టారు.
గెస్ట్ హౌస్ ద రేరెస్ట్ ఒకేషన్ అది, రేరెస్ట్ ఒకేషన్ రాత్రి. నేను అందుకే నిన్న యాక్చువల్ రానన్నాను, ఇవన్నీ చూసి వెంటనే రాత్రి వచ్చాను.
అందరూ మా టీచర్స్ మా మీద మమ్మల్ని తిట్టి మమ్మల్ని మాతో జోకులు వేసి
అప్పట్లో డిఫరెంట్ రిలేషన్ కదా. కానీ మహాపాపం చేస్తుందంటే ఆ పిల్లలకి ఏసి మహాపాపం చేస్తున్నారు. మెంటల్గా కార్డియాలజిస్ట్ రాకుండా ఉంటే అది వెరీ హ్యాపీ. 2 రోజులు ఆలస్యమైన ఎందుకు పాతిస్
ఆయన జస్ట్ చేసామన్నాడు, లైక్ చేస్తాను. యూ వాంట్ గో అండ్ డూ కేస్ విత్ డాష్. బాగా చేస్తాడు. నిన్న 3 కేసులకి బెయిల్అవుట్ చేశాడు. 3 కాదు, ఒక కేసుకి 14 కేసులు వాటి బెయిల్అవుట్ చేశాడు. హ్యాండ్స్ ఆన్లో 2 కేసులకి రాజేంద్రకి నేను బెయిల్అవుట్ చేశాను. అదే టచ్ అయిపోయింది. ఈమెయిల్ దాకా అవ్వచ్చు.
ఎలాగో లైవ్ చేసుకుంటే టైం
అనకాలి ఈ డాక్ వెళ్ళి వాళ్ళు ప్రిపేర్ అయిపోతే చేసేస్తారు. ఈలోపు 1-2 టాక్స్ కంప్లీట్ చేస్తారు. టాక్ లేదు, డిఫికల్ట్ ఫంక్షన్ డిఫికల్ట్ ఛాలెంజింగ్ కేసు మా వాళ్ళు ఇప్పుడు అది అప్లోడ్ చేస్తున్నారు సార్. లేదు కింద సర్జికల్ ఉంటుంది. అదో ఛాలెంజింగ్ కేసు పెట్టారు. రాజేందర్తో టాక్ అవుతుంది.
మీరు లైవ్ కేసుకెళ్ళారు
ఆయన మనం చేసేస్తాం కన్నా
నిలబెడుతూ వినిపిస్తుంది.
వాయిస్
Carry on.
Good morning, delegates and mentors. After a wonderful first day, I welcome all the delegates to the second day of our presentations. And we have started our second day with a beautiful demonstration of PBMV live case by Dr. Dash. Now we will start the scientific session.
బ్యూటిఫుల్ షర్ట్ అబ్బా, బ్యూటిఫుల్ షర్ట్ అది డాక్టర్ ఆర్కే.
అసలు ఇప్పుడు రామరాజు ఇంప్రెస్ చేయాలంటే ఇట్లా వేస్తేనే ఇంప్రెస్ అవుతాడు. ఏదో రేమండ్ స్టిచ్ చేసి హ్యాండ్ స్టిచ్ కష్టం రాజు ఇంప్రెస్ చేయాలంటే
అది కరెక్ట్, అది కరెక్ట్, అది కరెక్ట్.
ఫైనాన్స్ ఇంప్రెస్ చేయలేదు. రోజు చూస్తారు.
కస్టమ్ మేడ్ డాక్టర్ ఆర్కే లేబుల్ చేసి
మార్కెట్ చేస్తారేమో అంటారు డాక్టర్.
మీకు లైఫ్ చేసిన
కాదు కాదు
నాకు లైఫ్ చేసి ఉంది, నేను చేసేస్తాను చేసి డాష్
బట్ సార్ చేస్తాను
మార్నింగ్ వచ్చేసాను.
ఉంది సార్ 8 11:30 రాత్రి
ఎర్లీ వికెట్ ఆఫ్
సార్ ఇది కూడా శ్రీకాకుళం కూడా వెళ్ళేవారు కదా.
టవల్ చుట్టేవాళ్ళ
తెలుసు, నేను ఒకసారి వచ్చా సార్ కాస్ట్యూమ్ చేశా, సార్ కాస్ట్యూమ్ చేశాను సార్.
ఏంటంటే డిస్కనెక్షన్ సిండ్రోమ్ డిస్కనెక్ట్ అయితే అర్థం ఆల్కహాలిక్స్లో ఒక డిజీజ్ వస్తుంది, వైట్ మ్యాటర్ డిజీస్. మార్చి ఇంటర్నీ డిజీజ్ అంటే రెండు కనెక్షన్ కాదు, వాళ్ళే సెరెబ్రల్ డిస్కనెక్షన్ సిండ్రోమ్. వాడికి అడుగుతుంది మా నాయసరావు అనుభవం వస్తుంది, ఏం అడిగినా తీరిపోతుంది. ఇప్పటికీ అప్డేట్గా చెప్తాడు. డిస్క్రిప్షన్ వచ్చేసరికి సిమిలర్ డిస్క్రిప్షన్ అది బెల్జియం రాసుకుంటారు.
రిటైర్ మీకు మీరు రెడీగా పెట్టుకున్నారు కదా సార్, రిటైర్ అవటానికి అంతా.
the stasis of blood in left atrial is because of two factors. One is anatomical obstruction at the mitral valve level secondary to mitral stenosis, and atrial standstill because of atrial fibrillation will also leads to left atrial stasis. And endothelial dysfunction is also a proposed mechanism for LA clot formation. And few others have also proposed that the third component of hypercoagulability is also present in patients with RHD and MS. All these three factors will lead to development of left atrial thrombus. And coming to the important risk factors which can develop left atrial thrombus are, this is one of the beautiful study published in 1999 from AIMS. It is a prospective study on 200 patients, and they have concluded that in patients with severe MS, the presence of atrial fibrillation is the most important risk factor for the development of thrombus. And in the subgroup of patients with normal sinus rhythm, the presence of large left atrium and spontaneous SEC were considered as the high risk candidates for clot formation, and they might benefit from the prophylactic anticoagulation. And what is the incidence and prevalence of left atrial thrombus formation in patients with MS and atrial fibrillation? This study from Karachi has beautifully demonstrated that among 100 patients studied who had mitral stenosis as well as atrial fibrillation, they documented that about 38% of people had LA clots. Among the 38%, 6 patients had LA body clots, whereas the rest 32% had left atrial appendage clots. And in this study, they also proposed that left atrial diameter is a stronger predictor for presence of left atrial thrombus. Summarizing the findings, in normal sinus rhythm, about 3 to 13% will have LA clots, and in atrial fibrillation, about 1/3 of people will have LA clots. The risk factors for LA thrombus formation, summarizing the findings, this beautiful landmark trial from Dr. Manjunath from Sri Jayadeva Institute has this is considered as a landmark publication with thousands of patients included in the study. The risk factors are atrial fibrillation, as we have discussed, is the most important risk factor. And coming to the other factors, left atrial dimension of more than 45 mm, left atrial infero-superior dimension of more than 6.9, in TEE, left atrial appendage emptying velocity of less than 20, mean gradient more than 18, age more than 40, SEC grade more than 3, and previous embolic episodes. All these factors are considered as risk factors for LA thrombus formation. Now that we know that the risk factors for LA thrombus formation and the incidence, echo classification is also proposed by Dr. Manjunath et al., and it was published in 2009. LA thrombus was classically divided into 5 types. Type 1 is left atrial appendage clot. Among them, the 2 subtypes are left 1A. This is LA clot confined to the appendage. Type 1B is LA clot protruding into the LA cavity. Type 2 is LA roof clot. Type 2A is subclassification. Type 2A is LA roof clot extending above the plane of fossa ovalis. Type 2B is clot extending below the plane of fossa ovalis. Type 3 clot is layered clot on the IAS. Type 4 clot is mobile clot, which is attached to the free wall or roof of the IAS. And type 4 clot is the ball wall thrombus or free floating thrombus. And 2D echographic images, the image on the left one is clot which is present deep within the left atrial left appendage body. It is type 1A. This is clot extending into the mouth of the left atrial appendage, which is 2B. Image on the left is LA roof clot, and it didn't extend below the plane of fossa ovalis. And 2B is clot which has extended below the plane of fossa ovalis. Type 3, it is we can see in this image in this patient there are 2 different types of clot. One is type 1B clot, at the left atrial appendage clot extending into the left atrial body, and we can see a small layered clot on the interatrial septum. Coming to the this is type 5 type of thrombus, ball wall thrombus. We can see an organizer clot moving freely within the LA in patient of RHD and severe MS. Now that we have classified different types of left atrial clots, how to manage a patient with clot RHD MS. And the management depends upon the three important factors to be considered. One is valve suitability for PBMV, and the second one is clinical status of the patient, whether the patient is stable responding to treatment, or is the patient unstable requiring not responding to treatment, patients developing recurrent hospital admissions because of pulmonary edema, or in patients planning any interventional procedure. And the third important characteristic to be considered is the type of clot and its response to oral anticoagulation. Coming to different scenarios of managing a patient with RHD, MS and LA clot, and if the patient is unstable and requires an immediate intervention. Here we cannot adequately anticoagulate the patients, so any intervention will lead to high risk of cerebral thromboembolism and strokes. Here we have an unstable situation with severe MS and LA clot, and the first scenario is valve not suitable for PBMV. If the valve is not suitable, there is no other option except to refer the patient for a surgery. And second scenario is valve suitable for PBMV, and we have a clot of more than 2A. Clot of more than 2A is definitely an indication for surgery. And we have the third situation, clot less than 2A, that is the clot which is confined only to the left atrial roof, not extending below the plane of fossa vajalis, so that we can attempt and do a PBMV. But here, because this is an unstable patient requiring immediate intervention and we cannot anticoagulate the patient for 3 months, the risk of CVA is high. And if the patient if CVA risk is not acceptable, then we should send the patient for surgery. Type 5 thrombus, as we know, it is a ball wall thrombus, and it should be considered as an emergency because there are many case reports of sudden cardiac death being reported in patients with type 5 thrombus, and many patients present with syncopes. Coming to a stable patient with different types of LA clot, we have a stable patient and the valve is not suitable for surgery. We have no other option except to send the patient for valve is not suitable for PBMV, then we should send the patient for surgery. We have a second situation, we have a stable patient and the valve is suitable for PBMV, and as the patient is stable, we have time to adequately anticoagulate the patient and decrease the risk of embolic complications. And adequate anticoagulation with maintaining of adequate INR should be given for 2 to 3 months, and if the clot still persists to more than type 2A, we can refer the patient for surgery and PBMV cannot be done. And if the clot disappears or if the clot decreases to less than 2A, PBMV can be attempted after explaining the risks of cerebral thromboembolism. These are actually not, these recommendations are not from any guidelines. This is from the case reports and case series. And this important study from JIPMER has shown how the left atrial clots behave to anticoagulation. In this study was published in 2003, and in the conclusion we can see that left atrial clots are present in about 1/3 of patients with RHD and MS, RHD and atrial fibrillation. Isolated left atrial appendage clots in patients with rheumatic mitral stenosis and atrial fibrillation can disappear with long-term anticoagulation, while thrombi extending into the left atrial body may persist despite optimal anticoagulation. This is study which shows that left atrial appendage clots after adequate anticoagulation. Though we know from clinical experience, they have made a study on this. The anticoagulant of choice, as we all know, it is vitamin K antagonist. In some patients, the thrombus completely disappears, and few patients it may organize to a lower level. At what INR PBMV can be done? In patients taking an oral anticoagulant, it should be stopped at least 3 to 4 days before the procedure. PTINR to be checked on the day of PBMV, and PBMV should be done only when the PTINR is less than 1.5 to decrease the risk of bleeding. Coming to different techniques proposed by various authors for doing a PBMV in a patient with left atrial appendage clot or LA roof clot. There are two different techniques of modified septal puncture techniques and over the wire techniques. And this is the first and important publication showing which was done on a huge number of patients, and it can be considered as a landmark trial. And this was published by Dr. C.N. Manjunath from Sri Jayadeva Institute in 2009. Balloon mitral valvotomy patients, by balloon mitral valvotomy in patients with mitral stenosis and left atrial thrombus. Coming to these few details of the study, because it is an important trial which has showed that PBMV can be done in patients with some categories of left atrial clots. I have included this study group also. They have considered about 2,700 patients with symptomatic MS, and based on the study protocol, study group, they have included 108 patients with left atrial thrombus. They have included only type 1A, 1B and 2A, and rest of the candidates are in the control group. All patients in the study group underwent balloon mitral valvotomy by a different technique called over the wire technique, and it was actually a modification of a previous technique. And they concluded that in patients with mitral stenosis and left atrial thrombus of grade 1A, 2B and 2A, PBMV can be performed by modified over the technique. Coming to the steps, this is actually a diagrammatic representation of the procedure which Dr. Manjunath has described. This is the first picture shows that low IAS puncture. This is an intentional low IAS puncture. And after puncture, the Mullin sheath is to be kept at the mitral orifice, and the coil guide wire is directly introduced into the left ventricle. And over the coil guide wire, which is in the LV, septal dilatation and balloon exchanges will take place. By this diagram, we can see that most of the left atria as well as the left atrial appendage are excluded from the path of entry of the wire, as well as balloon dilatations, as septal dilatations and balloon dilation. So the risk of thrombus they have proposed was very less. And actually I have got, I am lucky that I have seen one or two procedures performing being done by him, and I have few recordings also. This is a low septal puncture technique, low intentional low septal puncture, and placing the Mullin's sheath at the mitral orifice area, and they can negotiate the LA wire into the directly into the LV. And over the wire, the Mullin sheath is tracked directly into the LV, so that they can make adequate coiling into the of the LA wire in the LV. And third and most important step is the PBMV balloon will be tracked directly into the LV. Here there are few technical this thing, the deslenderization and all is to be done only when at least 2/3 of the balloon crosses the interatrial septum. Only through that technique only the balloon will enter the left ventricle directly. This is tracking the PBMV balloon directly into the LV over the coiled guide wire. Once the balloon enters the LV, and PBMV will be done in a regular manner by sequential stepwise inflation of the distal balloon, proximal balloon and the waist. By doing this procedure, by putting the LA guide wire directly in the LV, they have reported that 100 patients, all the patients have developed PVCs and few patients have developed NSVT episodes, but none of them were hemodynamically significant and none required an intervention. The results are comparable, significant and comparable to the regular procedure, and they have documented that there are no thromboembolic episodes during the procedure, and only one patient in the study group had a transient ischemic attack which developed after 6 hours of successful PBMV, and the patient was completely recovered after 12 hours of the procedure. Only one patient in the study group had developed cardiac tamponade needing an aspiration, and there was no in-hospital death in the total study group. When I asked the senior colleagues performing live cases yesterday, how difficult is this procedure to do? Many have opined that they have not done or this thing, but in this study also they have proposed that this technique was done by operators who have done at least a minimum of 500 cases individually. Considering that as a landmark technique, landmark trial for doing PBMVs with left atrial roof clots and left atrial appendage clots, there are few case reports who have performed PBMVs with left atrial clots. This case report was published recently in 2022 in a patient with restenosis and left atrial appendage clot. Due to hugely dilated LA, they have taken a superior anterior puncture. The left atrial appendage is an anterior structure, and they have taken superior anterior puncture, and the coiled guide wire has gone more vertical and avoiding the entry into the left atrial appendage. With this is only a case report of a different puncture technique, the superior anterior puncture. And one more small study from including 23 patients from they have published from AIIMS and Nepal together. Once they have entered, once the Mullin sheath enters the left atria, they have taken an LA angiogram shoot, and this was put as a landmark. And all the though we know the fluoroscopically where the left atrial appendage lies, they have done a left atrial angiogram, and they have carefully negotiated the wires, balloons, and septal dilatation below the level of left atrial appendage. And few case reports were there where the PBMV has to be done in patients with in emergency situation with cerebral protection devices. In this study, only 2 cases of PBMV with bilateral carotid protection device were done. One patient was critical MS in congestive heart failure with hugely mobile left atrial thrombus, and they have to intervene early. Whereas the second patient is an young patient who declined surgery and had an left atrial appendage clot which did not respond to the warfarin therapy. By this bilateral carotid protection devices, they have done PBMV. Yeah. These are different case series and individual cases where PBMV was done with left atrial appendage clots. With this, I conclude my talk, sir. I request seniors will have some throw some light on the topics, madam. Here actually we have not done such cases. Actually This is me, who has seen few cases when I worked in Sri Jayadeva Institute, Bangalore, madam. Here in Kim's Hospital, we have not done. Yes, ma'am. All patients, even in sinus rhythm or atrial fibrillation, mandatory, madam. All the cases which were posted for today also, today and yesterday were also, TE was done. Because paroxysmal atrial fibrillation, and they have reported that even in...
Suppose if you are doing TE, when will you do the TE? That on the day or day before? Or
Actually, it should be done on the day, because there are chance that clot might have formed. But here we have done yesterday, sir, for one day before we are doing.
yeah, that's also important, particularly
Yes, sir.
in atrial fibrillation patients. The prior TEs may be normal, and on the day they may have a
On the day or just before day we are doing, sir. Here regular practice is like that.
Tolerate that's nobody knows the answer.
Difficult question, sir. NOACs are not indicated.
What did you do?
I feel giving Novax in those patients is equal to not giving. It's a waste of money because there's no benefit.
There is a futuristic study, I don't know whether it will be right, they say hypersensitiveness, no?
They were given actually rituximab. On rituximab, if you give VKS, I believe they tolerate the drug better. There are studies, publications.
Yes, sir. We'll check it.
Yeah, but Padmanabhan, I feel what is important is especially a lot of youngsters are there in rheumatic mitral stenosis, atrial fibrillation, mild mitral stenosis. So still mild to moderate. Don't give Novax. You have to give off.
No, moderate to severe MS, no Novax. But we have certain patients with mild MS,
Yeah,
moderate
so-
MR, atrial fibrillation, not tolerating. You can still give Novax.
Which one? Yeah, you try to tell them repeatedly. You look for other causes. Like what happens, a lot of the patient have a lot of bacterial colonization of the colon. See, all vitamin K detectant factors, there's a colon dependent. So you have to look for those causes. We have a lot of patients post-op MVR and INR is like anything, 0.5. Then we looked at some colon, they had some problem, we treated, they do well. So you have to look for other causes. But especially the youngsters I have seen, especially some of them, even mechanical prosthetic valves, they are keeping Novax. So you should not do that. It's very important.
The other way, this hypersensitivity, no, there are some studies, what they did is, you can give along with oral vitamin K, so that the bleeding, that is also, there are studies. You give oral vitamin K, along with that you give a vitamin K antagonist. High INR you give along with oral vitamin K.
So again be careful. Oral vitamin K with a valve in a mechanical prosthetic valve.
Yes, sir.
Again, and it's just situation because all seniors are telling this, so you have to be careful. So that is in a situation of a moderate mitral stenosis with atrial fibrillation. INR is high with a small dose. So you can give there also because mechanical prosthetic valve, please don't mess up. Don't mess up. Please, WAF. VK. Come what may happen. Let him have 4 bleeds, 4 prolonged INRs, hospitalization. It's a VK.
No, so that's what if it is bleed, it is doctor's fault. If it is stroke, it is God's fault.
That's okay. That's how it is.
Reality of the day.
That's not the reality, but then we have to understand that we have to practice medicine the way it's supposed to. No, Novax.
Thank
Because I know it's very easy to prescribe a Novax. There's a lot of pressure from the pharma also to provide Novax. That's all okay, but then at the end of the day, we should practice good medicine.
Yes.
Recently one study came in prosthetic valves. With
Vitamin K was better.
Apixaban, React 10A study. Quite a large study. After 3 months of surgery, they put and again it proved both thrombotic and bleeding was higher with apixaban also. Earlier we already had a study with dabigatran, isn't it? This is the second from Canada. This is very recent, about.
The first one was from Canada. And this Canada, I don't know why they are very favor of.
That one, dabigatran, they gave 330 milligrams BD. Despite that, both the readings were.
The aging population is very high.
What is it? Revolve or something. That is with dabigatran 330.
We have done at least 4 to 5 cases along with Padmanabhan, that direct crossover. We have done a few, but right now our numbers have come down, so hardly we do. We used to do good numbers 4-5 years back. Now we hardly do 1 or 2 PBMVs per month.
Actually, at least minimum of 3 months, sir, we are giving.
But in fact, most of the patients we did, the clot disappeared, and
Yes, sir.
they did well. Yeah. Yeah, therapeutic INR should be there. It happens that you have to take, sir, the 2-3 things are.
20% it never happens.
Yeah, that's a problem. Yeah, but that's. Yeah, that's what. It needs lot of patience, sir. Okay, that's. Yeah, but right now I think there's more standardization of INR. At least some standardization has come, sir. Definitely. 10 years back, what was there? Now it's definitely improved. And I think the. Yeah.
Our Indian setup, put a bioprosthetic all cases. At least 15 years, 10-15 years of quality life is there. He or she can eat anything she can. She can take any medicine she or he can.
No, sir. Sir, our surgeon will be very happy, sir. No, not our surgeon. If it.
Non-vitamic antagonist you can give. Bioprosthetic? No, it doesn't matter, sir. No. If he become double severe MS, rheumatic, now they say non-valvular artery fibrillation is till moderate MS, non-valvular artery fibrillation. If more than moderate MS, valvular artery fibrillation. Up to moderate MS, non-valvular artery fibrillation. More. No. Yeah. You can be lenient, but not very stringent. Not stringent. Not stringent. And you can give that is 1B indication. You can give, sir, that non-vitamic antagonist. Yes.
But in fact, what some people have suggested, sir, mild mitral stenosis, post PBMV, atrial fibrillation. There is one group in India. You must be knowing all of that group. They are doing LA appendage device closure so that a future thrombus which can form in mild MS atrial fibrillation can be prevented. And in fact, all of us who are having good number of patients with rheumatic heart disease, post PBMV, atrial fibrillation, they are landing in next 5 to 10 years with a massive stroke or with a peripheral embolism. I have seen losing the limbs, upper limb, lower limb, so many patients. Yesterday we had one patient here in the workshop. Mitral stenosis, normal sinus rhythm. 3 months back, he had above knee amputation. Normal sinus rhythm.
No, that could be paroxysmal achievement.
So, what that group says is, mitrals post PBMV, they do BBMV, atrial fibrillation, mild MS. These people are more prone for high risk more than people who are having atrial fibrillation with structurally normal heart. This is a subset of a patient with a rheumatic heart disease, with a mild stenosis, with an atrial fibrillation. They are more prone. The incidence of thromboembolism is high in these patients. So you have to give anticoagulants, and we have seen our practice, at least I have seen, number of patients coming back, mild MS, devastating thrombus, devastating stroke, devastating embolism.
No, no, no. See, this is, Sujata, this is a very controversial aspect. See, no, please remember the thrombus formation in non-valvular atrial fibrillation, more than 90% it is in the appendage. Whereas in valvular AS, it is only about 60% in the appendage, rest all are in the body. So the preventive ability of your appendage closure is not as good. It is only 2/3.
I am not recommending LA appendage device closure. What I am telling you is, please give VKA in a mild MS with atrial fibrillation. That is my take on this. I am not advocating LA appendage. I am not telling, I am telling you why I am quoting that study group is the importance of stroke in a patient with a mild MS with atrial fibrillation. I am not telling, no, yeah.
We have a lot of evidence, no? In the non-valvular AF, the chance AF, non-valvular, it is about 5 times higher than the general one. Valvular, it is 18 times higher. So you have to realize the seriousness of the issue and anticoagulant.
Lab now? Lab started? Lab started?
Yeah, you are audible, Lakshman. Yeah. 1 minute.
Have you any echo picture there?
And I request Dr. P.K. Das sir and Dr. R.K. Jain sir to moderate this session.
Can you show a better picture? Yeah.
These are.
You play that play. No, that is okay. Fine. Play.
These are echo images, sir.
Yes, sir.
Parasternal long axis view.
Go to cross section. Cross section, mitral leaflets, mitral valve.
Long axis view.
Share some
mild MR, sir. Yes, sir.
Not audible.
This parasternal long axis. That is okay. This is
yes. So
short axis view, sir, at the mitral.
Do you think there is nodal there is a lateral nodal?
At the lateral commissure, sir.
A nodal there.
Mitral valve area of 0.6 centimeter square.
So unicommissural nodal not an contraindication for mitral valve.
Dilated LA. Mean gradient of 12. Moderate pH. T was done, and the patient doesn't have left atrial appendage as well as left atrial clot, sir.
How many days before done? T? Yesterday?
Yesterday, sir.
Okay.
Procedure T was done yesterday. Okay, Lakshman, you can go for the procedure.
Am I audible?
Yeah, yeah.
Yes, sir, you are audible, sir. You can sit there.
Ramaraju. So I don't know how many junior interventional cardiologists are there left-handed. So can you show the left-handed interventional cardiologist doing PBMV, ticks and trips? Because I knew when Ramaraju joined, I was yeah. So so yeah. So yeah. So he's ambidextrous, correct? You work as if you are right-handed, correct? Yeah. Yeah. So it's important point. So when he joined, he had this doubt what to do. I said, don't worry, you will get used to this. So the way he's managing the catheter, I knew that he's a left-handed person. Leave it, you should. Please show the fluoro also. Yeah. Raju, are you confident doing septal puncture in AP or RAO? But lateral only. Lateral. Fluoro please, fluoro please. Yeah. Yeah. So by doing this step, what he is doing is avoiding the sudden jumping of the Mullin's dilator and touching the LA roof. So what he is doing is, normally what we still practice is, we do a puncture, then the needle, will withdraw the needle, push the dilator little inside LA, stabilize the dilator and thread the sheet into the LA. So then at that time you have to be very careful that the dilator should not jump and touch the LA roof. That can cause perforation. So he is avoiding that jumping of the Mullin's dilator and touching the LA roof. That's what he is doing. Yeah. Dr. Dasher, now this there are some questions in the audience that this is a, you think this is a clockwise loop of the spring wire. If it is a anti-clockwise loop, that is the whole spring wire is on the
left side. Right side.
What does it indicate? It indicate a low puncture?
Low puncture.
Yeah.
I have difficult to negotiate the balloon from LA to LV.
Okay.
So this is optimum position of the LA wire.
This is probably a mid puncture.
This is a good puncture, sir.
or high puncture?
It is the optimum site.
Optimal site.
Suggest that we be positioned to the left side when it is on the right, the wire, by using the position and
No, you cannot.
you are not happy with the puncture. You have not passed the sheet pullings or anything. Do you think we can, if you're not happy with the puncture, do a repuncture?
Yeah, repuncture. Yesterday we had like that.
After dilating the septum, you want to repuncture. If you're not, something, let me say your balloon is not entering the LV, you're facing significant issues. Would you recommend redoing the procedure?
Yes. How much LA pressure that time? That have to reverse it. Huh? Okay, LB, that's, yeah, you have to reverse it. So LA is mean 14 only. 14, 15. Katlab, the reverse that. LA should be LB and LB should be LA. Yeah. There at rest there no gradient, not much gradient. So you have to give fluid or increase the heart rate, give atropine. Or infuse some fluid. Yeah, that you know that, but here you change that the labeling should change. You change the labeling. LB should be LA. No, you have to give no more fluid. Now LA mean is coming 18 and 19 something like. You change the labeling. You have to change the labeling.
Ramaraju, tell your technician to change the labeling. LA is 59 and LV is 17. Please change the labeling so that they'll not. Okay. Second, what is suggesting, because the gradients are not there, give some fluid challenge. Because if there, still there are no gradients, probably we overestimated valve area and the gradients, and you can back out. It has happened many times. Many times. Nizam days, so many times. So all of us have gone through this. It's okay. We have overestimated, and that's okay still. Yeah, at least you demonstrated to the audience how to do a septal puncture. That's important. That's also a teaching. So hemodynamics is very important, and you should be very good in hemodynamics. And then if there's no gradient, it's okay. You are still benefiting the patient. I know. No. Yesterday we had this discussion. In a situation, we again summarize as what we had discussion. So, septal guided puncture in a TE, it's a learning, definitely no doubt. But in a situation of a mitral stenosis where you want to do PBMV, where you can get away with any puncture, you can cross the wall. So it's not very important that you need a posterior puncture, you need a mid puncture, you need exactly high puncture or a low puncture. But when you are doing structural intervention like LA appendage device closure, TMVR, then you need to have a TE or an ICE to exactly puncture where it is recommended. Otherwise, you can't deliver the device there. So again, doing a TE, transesophageal echocardiography, during PBMV, it's a little cumbersome procedure. Patient will not cooperate. People for ASD, they have stopped doing transesophageal echocardiography. So it's a good idea, but again, when you want to do this, but if you start telling that all PBMVs have to be done under TE guidance, Ramaraju couldn't have done a PBMV because when he started the program, we used to get the TE Pro from Hyderabad. Morning. Yeah. To learn again, again PBMB who is doing very low, where the budget is low, again do a TE, where the volume load is so high. So like the PBMB is like Ramaraju, if we start doing TE to learning curve, it is not practical. I know ideal situation where you have less work, then you do 1-2 PBMVs a day, nothing else, you don't have outpatient, you don't have emergency primary, then you can do it. But then
the other thing, do you, at sometimes when there's a lot of subvalvular fusion, you want to be sure that you are in the valve. So at that point, do you use echo guidance to just see where you are?
yeah, again subvalvular you can yesterday Dr. Dash has shown there's something called balloon impasse. So if you have that sign, then it indicates it's a subvalvular fusion. So you can get out. Because doing a TE again to find out subvalvular fusion is a cumbersome. You will not be able to image mitral wall. You need to get a good 4-chamber view. You should align well. Patient is conscious. Transthoracic, transthoracic you can do. What is it? So after 100 ml the gradients are low. So I think but if you see long cycles, hardly any gradient. So again, I think it's very, very important message for all the junior interventional cardiologists. Hemodynamics are very important part of your interventional cardiology. Don't forget hemodynamics because you are very young. Next 10 years later, you'll be doing only structural heart intervention. So if you're not good at hemodynamics, you are in problem. So you should have patients learn hemodynamics. And cardiology is nothing but hemodynamics. No, we don't do invasive hemodynamics. We assess by echocardiogram. But when we do high risk intervention, people where complex intervention, we do PA monitoring. We keep a catheter in pulmonary artery and we continuously monitor PA pressures. And if at any point of the time the PA diastolic increases, we start giving in the same catheter nitroglycerin. That is the first alert that the patient is deteriorating. So what we do, we keep a PA catheter, and if the PADP increases, we give nitroglycerin, and then start for additional support, hemodynamic support, intra-aortic balloon pump, or Impella, or more worst cases an ECMO. So this has really helped in last couple of complex cases. That's what our protocol now is. Especially if we think that the need for a mechanical circulatory support is needed, then we keep. And it's a complex intervention, single surviving vessel, or you think that you might occlude a branch vessel which you want to protect, there might be delay in opening that artery. In those situations, we do it. And our other thing is to scale down. What we do, we keep a venous line ready. We don't keep a PA catheter. But if you think anything, we just push a PA catheter and then start monitoring again.
You can put anything. He's saying his question is PA catheters are the...
Okay, so now PA catheter is nothing but a wedge catheter, or if wedge catheter is expensive, we put a multi-purpose catheter, we put in pulmonary artery. Simple multi-purpose catheter. So Ramaraju, it continues to be low.
Yes, yes, sir.
So it's at least good that, hope you are not doing PBMV, correct?
So here, the importance of hemodynamics in over and above echocardiography,
Yeah.
and we could nicely demonstrate how to elicit
So what are you doing now? Okay, okay. You have given heparin, no? Okay, good.
Ramaraju, in your experience, how many times did you have to do a pericardiocentesis?
Ramaraju, PBMV cardiac tamponade, your experience.
yes, sir, we had a couple of cases, and many of the times the sending to surgery is, in spite of tamponade, we have sent surgery in only 20% of the patients. The rest of the times we complete the procedure and we manage somehow without sending to surgery.
No, tamponade have you sent for surgery or tear?
Tamponade we aspirated,
Yeah.
majority of the time the rent got closed.
Okay. So very important point is when you are doing a balloon mitral if you get a tamponade, before you do inflation, do a pericardiocentesis, stabilize the hemodynamics, and do PBMV. If you don't do PBMV and with a tamponade, in spite of draining, by the time patient go into theater, he might crash. So, yeah. What Ramaraju, what do you say? How many pericardiocentesis you had before balloon crossing? You had a tamponade. So you put a drain, you finished PBMV. Yeah, that's very important thing.
And we had a couple of cases of fracture of LA wire also during the procedure.
I'll show you those. I'll show in my complications all those.
A couple of cases we wrapped and removed.
Yeah.
And in spite of the fracture, we completed the procedure.
Yeah.
First finish the procedure.
Yeah. So I'll show you some of the cases in complication. Yeah, better. Thank you. So it's very important that in a mitral stenosis, especially symptomatic mitral stenosis, if you don't do the procedure and come out, if you have a complication, they do worse. The other important thing I think I wanted to stress yesterday, I forgot. Any patient with a severe mitral stenosis with a severe pulmonary artery hypertension and an RV dysfunction. So what we do PBMVs, we keep them NBM. Okay, overnight NBM because of surgical standby, all these things. The patient are dehydrated. Already patient is in a good diuretic. So you do a balloon mitral valvuloplasty. After doing balloon mitroplasty, the patient's cardiac output is increased. But there is another PH there, another block, resistance. The PH takes time to regress. So these people, post-procedure, they are more prone for hypotension and shock. So these patients, post-procedure, you make sure they hydrated well. Especially make a conscious effort to orally hydrate them. We had couple of patients like this, doing everything, suddenly they crash. And then we resuscitate, we give natropine, and then we give lot of fluids, they recover. So any patient with a double stenosis, a mitral stenosis and a PAH. Okay, so you have to be careful. Once you do mitral stenosis, the PH time takes to regress and the obstruction gets relieved little later because of the PAH. So you have to be careful with hypovolemia in these cases. This has happened in many of times for us. So really careful, post procedure we hydrate them. is punny? Where is punny? What is next? Doctor, yeah, go ahead.
I request our Chief Cardiothoracic Surgeon to present his talk on handling the complications of PBMV. Over to Satish sir.
Good morning, all. I hope you had a good session yesterday and wish you have the same thing today also. With so many experts operating, probably my requirement as a surgeon is not required to manage any kind of complications occurring during PBMV. But a few instances we require urgent surgical intervention that we'll try to see in next few minutes. So just to brush, RHD continues to be endemic. Isolated MS occurs in nearly 40% of all patients. So to come to evolution, the concept of mitral commissurotomy was proposed by Brunton in 1902. The first successful surgical mitral commissurotomy was done in 1923 by Elliot Cutler. Then the technique was popularized in the late 1940s and early 1950s by Harkin and Bailey. Then with the development of CPB, cardiopulmonary bypass, in 1960s, open mitral valvotomy and mitral valve replacement became the treatment of choice. As yesterday also discussed, Inoue, a cardiovascular surgeon from Japan, designed this balloon in 1976. Primarily, this balloon was designed to create an ASD in TGA. Then he used this same balloon to dilate peripheral vessels. Then in 1979, its ability to separate the fused commissures was established, and the balloon was perfected, and the first case was done in 1982. Closed mitral valvotomy, balloon mitral valvotomy and open mitral valvotomy were compared in randomized fashion, and all had comparable good short and long term results. Then approved by FDA in 1994. Since then, closed mitral valvotomy and also for some extent open mitral valvotomy has become almost obsolete. Probably next talk, Dr. R.K. Jain will explain all the complications of PBMV and their management by intervention at cath lab. I am just going to brush complications which require surgical intervention. The device related complications are breakage of coiled LA wire, which if I could not retrieve the photo 6-8 months back, I removed a breakaged coiled wire. The entrapment of pigtail guide wire also we removed just 2 months back from the femoral vein. And during transseptal puncture, hemopericardium and subsequent cardiac tamponade is the deadliest complication because of LA rupture, LA puncture or RA puncture, LA appendage perforation and very rarely LV perforation. Systemic embolization, iatrogenic ASDs, aortic root puncture and acute MR. So probably vascular complications are the most simplest complications which we get. The usual vascular injury will be a vessel tear or uncontrolled bleeding after removal of the sheath, hematoma, pseudoaneurysms which requires vessel repair on an emergency basis. Peripheral embolization from thrombus from LA or LA appendage may require thromboembolectomy. When sternotomy is required in PBMV, after PBMV, I think there is only one emergency requirement for sternotomy and management is massive hemopericardium, cardiac tamponade, which is unresponsive to pericardiocentesis. Probably all others, we have some time to breathe and we can plan and go to OR. And severe acute MR leading to hemodynamic compromise or having refractory pulmonary edema also requires an emergent mitral valve replacement. Coming to hemopericardium and cardiac tamponade, this is one emergency, as I said, requiring real speed to save the patient. Probably this is because of high septal rupture in cases of large LA or RA, and also exaggerated movements of devices, balloons or guide wires inside the RA or LA. And this diagram shows if the puncture is towards A, we may perforate RA. If it is towards B, we may puncture the roof of the LA. And if it is towards C, a LA appendage perforation can happen. So management, patient suddenly on table develop chest pain and unexplained hypotension, and usually identified by transthoracic echo, which is available next to the patient, and pericardial hollow under fluoroscopy. Immediately pericardiocentesis is done and auto transfusion started. And if the patient is not stable or becoming unstable, keep all the guide wires and devices in C2 and shift to OR for for surgery. So we do emergency sternotomy and drainage of the pericardial fluid. Usually the rent is seen in the roof of the LA. Whatever 2-3 I have seen, it is in the roof of the LA. Sometimes RA body is also seen, and that is repaired, and usually balloon mitral valvotomy is not over by that time and it requires an MVR. Next deadly complication is acute mitral regurgitation. So we all know the mechanism of PBMV is commissural opening. So this may aggravate MR, but usually it is not significantly worsen the functional status or long-term prognosis. And severe MR can occur between 2 to 15% in different series. The main reason is, as you all know, unfavorable valve anatomy, inappropriate balloon sizing or inflation protocols. So the causes to be listed: undesirable transmission of balloon pressure forces, when there is uneven thickening of the mitral leaflets, that is uneven calcification, severe and extensive commissural fusion, thickening and foreshortening of subvalvular structures, a fibrocalcific dystrophy of commissures of paracommissural areas. The mechanism of MR is exaggerated commissural splitting is one, non-commissural tearing of anteromitral leaflet or postmitral leaflet with disruption of the valve mechanism is next common. And damage to subvalvular apparatus is rarely happens, and very rarely papillary muscle rupture can happen. So timing of surgery. Usually these patients doesn't require very emergency surgery. We have some time to breathe. We can first determine the timing will be determined by the clinical tolerance, hemodynamic stability, the mechanism of MR and surgical risk. Usually a mild commissural MR has no clinical consequences and can be followed up. A moderate MR can be followed up and few regress over a period of time, and if that progresses, then a planned MVR can be done. And if the patient is hemodynamically unstable, mechanical background of MR is severe and irreversible, that is leaflet tear, either AML or PML, emergency or early MVR is required. Definitely if there is an emergency surgery, surgical risk will be very high. In these patients with severe left atrial pressure and also unrelieved MS, and patient going into pulmonary edema, the risk is very high. These patients will develop right ventricular subendocardial ischemia, and early RV dysfunction is seen. So I have seen RV dysfunction in 1 week also after acute MR. So these patients should be recognized and early MVR has to be done. And if we delay too much, patient will go to low cardiac output, a multi-organ dysfunction, and surgical risk will be very high. Next is iatrogenic ASD. The incidence of IASDs is between 20 to 50% or some series 90% after transeptal puncture and may persist up to 3 years. This happens when large sheaths are used. If transeptal puncture is not in fossa ovalis, or if the if there is large LA, residual MS, chances of IASD persisting is high. Usually IASDs on fossa ovalis closes over a period of time. If IASDs have significant shunt on follow-up, and if develop any pressure or hemodynamic indication, should be operated. Most ASDs decreases in size or disappear. I see nearly some 3 to 4 patients with a left to right shunt which requires closure by direct suturing out of 10 post PBMV MVRs. Rarely a right to left shunt can happen because of severe PH, and if mitral valve surgery is warranted, it can be closed at surgery. Aortic root puncture. There is a narrow edge between luck and catastrophe if this happens. A transeptal puncture it can happen from RA to non-coronary sinus or RA to sinotubular junction, which are comparatively less dangerous. It can produce hemopericardium and cardiac tamponade. We can do pericardiocentesis and manage, and we have some time to shift to OT. But if the transeptal puncture from RA to ascending aorta happens, it's very dangerous, and immediate cardiac tamponade happens, and these patients have high mortality also. Should be treated with pericardiocentesis and immediate surgery. Keeping all the wires and sheaths in place is very important. This is the diagrammatic representation of the same. So to conclude, mitral stenosis is a long-standing sequelae of RHD. PBMV is a minimally invasive transcatheter procedure. It's a procedure of choice for young or any patient with favorable valve morphology. The results are good, low risk. Complications are very minimal, Complications which require surgical interventions are mainly cardiac tamponade, acute MR, or inadequate dilatation. Even though there are different risk scores like Wilkins or Nobuyoshi scores for 2D, there should be more emphasis on 3D echo, CT scan, MRI, which yesterday sir discussed in detail to obtain better results. And complications requiring surgical interventions are less, but if happens, needed to be addressed very fast. Thank you.
So it's very important that you need a very good relations with your cardiac surgeon. It should not happen seeing that cardiac surgeon is your competitor. It's very important because you have to work with them. All the cases, when they feel uncomfortable, they send a mitral stenosis to you. When you are not comfortable, you can send to them for an MVR. But we need them, especially in a PBMV situation. They should be able to handle and then take out the patient out of the hospital. So you should have very good relation with these cardiac surgeons. So that's what we learned. So until we have the cordial relations, they will hesitate. They'll have difficulty to talk to us and bail out in a bad situation. Second thing is, he has lot of experience about mitral valve replacement. He was just quoting all young mitral stenosis who are going to become plan a childbearing age, or people who can't take anticoagulants, who is doing prosthetic wall instead of a mechanical wall. The durability is 10 years, but at least given the issues of anticoagulants, just now we discussed 5 minutes back, it's not a bad situation. In fact, in US now they are recommending it's better to do a redo MVR by a bioprosthetic wall rather than put in all the stress. That's in fact now it's going to come in guidelines after some time. So, but India again redo surgery, the cost of surgery. But he said to me that even redos he is doing in Aragishree. So I think we're already in America here.
In that aspect, we are very much honored, and lot of backup Satish gives us. In any bad crisis state, whether it's a coronary or mitral or congenital or a device closure or whatever it is, in the middle of the night also he comes and does surgeries. And with that backup we could do lot of cases. And doing left main cases, we are very much comfortable. Even at any odd hour we do our left main cases, because our cardiac surgery team is always ready. Even when you call in odd hours also, they will be ready to come and operate. That is with that help of and the CT surgery team only, we could really do some wonders in cath lab also. Thank you, sir.
Thank you, sir. Thank you very much.
In the last live case, I think you might have observed the differences between an echocardiographic assessment and a hemodynamic assessment of mitral stenosis, how it varies. Really, the last case, there are a lot of learning points. It's not that we did not do the case, but still, careful assessment of the hemodynamics is very, very important. In the first live case, when Dr. Dash said, did the case, it is the hemodynamics which predicted that the patient might have developed a mitral regurgitation. When we carefully observe the LA pressure tracings pre and post procedure, any sudden increase in the V wave in the left atrial pressure tracings, it gives whether you have an echo in the bedside or not. If you can just observe the LA pressure tracings, and if there is a sudden increase in the height of the V wave pre and post procedure, it gives a clue that there is probably the patient had a mitral stenosis. And sudden increase in the LVEDP, sudden increase in the height of the LA V wave it gives a clue that probably you should stop there because the patient might have developed mitral regurgitation. Whether you have an echo machine bedside or not, it's not always everywhere every time echo machine will ready in the cath lab. But before that, if you carefully observe the tracing, that's why careful study of the hemodynamics is very, very important during cath lab. Any process, sudden increase in the LVADP. Earlier days when we used to do angiograms, it's always, especially in the exams, we used to do mandate pulmonary wedge pressures before doing a angiogram, because many of the times when we stop this practice, because there are fallacies in assessing ejection fraction by the many of the cardiologists. Many of the I may give is a severe dysfunction, he may give is a moderate dysfunction. So some inter-observer variability. We are not that perfect in calculating, to be frank, in ejection fractions, because most of the times 90% will be giving eyeball measurements of the ejection fraction. But if you just by ignorance or by just overlooking, if you do an angiogram in a severe dysfunctional patients, majority of the times they develop left ventricular failure post angiograms. These mistakes can be readily overcome by careful performing echogram. To overcome that only, earlier we used to perform check the pulmonary wedge pressures before doing an angiography. But nowadays everyone stopped that doing. But earlier it's always mandate. Do a right heart catheterization, check pulmonary capillary wedge pressures. Suppose the pulmonary capillary wedge pressures are high, we used to give some diuretic, wait for some time. We see that until the pulmonary wedge pressures have come down, we never went forward to do a intervention or any angiography. Huh? Yeah, now LVDP is very, very important.
Thank you, sir. Now we move to the next session, and the next session is on management of complications during PBMV. I request our next speaker, Dr. R.K. Jain, sir. He is the director, KIMS Secunderabad, and head of the department. He is a prominent national and international faculty with more than 41 international publications and 30 national publications, and actively in research with multiple clinical trials. He is our teacher and mentor, and he is an inspiration to many of our young cardiologists. I extend my warm welcome to you, sir, and we'll start this session. Thank you, sir.
Every time a new intervention starts, R.K. Jain will be the first person to do that procedure. He'll never sleep until he does the procedures. So every time with a new procedure, new look, this is his fresh look. What, Jain? With every new procedure, you'll be changing your profile. And what is the secret for this? Any new procedure? Yes.
So it's important to let it be anything in cardiology. So you have to be at the cutting edge. You should try to do everything, and you should dedicate yourself most of the time to cardiologist. So a lot of people told recently in KIMS that why you want to practice cardiology, you can stop and go into administration and other things. So I said, there are a lot of better administrators than me. So if I go into administration and do things and finance, nobody will recognize. I will be one of the same fellows. But if I am administrator also and finance also, I am a cardiologist also, I'll get more recognition. So people will come to me as a cardiologist rather than an administrator. So my passion is still for a lot of cardiology, and I have lucky enough to have very good mentors. My two mentors were here. Dr. Vasant, I think he's doing some live case, and Dr. Padmanabhan. These two people really, Vasant was my mentor from MBBS days. So he, throughout my MBBS, he taught what to do, what not to do. And my MD days also he mentored us, and even DM. So then Padmanabhan was there with us in my journey through cardiology. Coming to my topic today, whenever you do PBMV, unless if you see all the complications and you know how to deal with them, you'll go into very difficult state and you'll get jittery and then you'll get panicky and all. So complications are bound to occur. There is a famous saying, somebody says, I never had a complication. It is like a gynecologist telling, I've done 1,000 hysterectomies and never had a vesicovaginal fistula. Only two things are there. Either she is not done 1,000 cases or she is not telling correct. So complications are bound to occur. So you should not be worried that complication will occur, I will not do this procedure. They are bound to occur, and somebody says not occur means is not true. Coming to PBMV, these are the reported complications which are very bad. In-hospital death is not much, 0.1 to 0.2 from various series, Aurora series. Second is cardiac tamponade, that is also 0.8 to 0.6. Then third, other complication is embolic event. Strokes can occur, though it's very, very important. And severe mitral regurgitation. So I will go one by one how to prevent this. First is severe mitral regurgitation. So it's very important that all of us have to, any mitral stenosis you do, you have to check the valve yourself, because the echocardiographer, whatever experience she has, you have more experience than the echocardiographer, and you check yourself. Sometimes they give a score of 9 and it will be 12 score. So you might land up on the table and trying to dilate the valve, you might land in problems. So prevention of severe mitral, you check your valve yourself, auscultate the valve. If it is not pliable, be careful, that may land in problems. Sometimes the patient might have a moderate to severe MR, they would have missed already existing MR, you try to do PBMV. These are things. Second, the cause of MR are three. One is non-commissural tearing of anterior and posterior leaflet. This is very dangerous. And if you don't recognize, you leave it, you have time up to 12 to 14 hours or 24 hours. And if you don't adequately diurese them, look for hypotension, they will crash in the night. So you have to recognize AML and PML tears. So normally this AML PML tear occurs when you have a very bad fibrosed valve. Instead of opening the commissure, you will tear the AML. We have seen PML tears, but AML tear is more common. Recognition of AML tear by echocardiography is important. Recognition of severe MR, you will have a prominent V wave, tachycardia, pulmonary edema. But is the MR because of the tear or because of the excessive commissural splitting? That you have to recognize. So for that you have to be a good echocardiographer. I will show you a picture. Very easily you can tell it's AML tear, but many times it's not easy. So there is certain very classical findings in AML tear which I show you. So you have to recognize that. So if you recognize this AML tear and catch it and alert a surgeon and alert your junior colleague or the resident on the duty that this patient you watch in the night, it might collapse. So it's very important. Like I said, same day surgical MVR might be needed in 2 to 3% of the patients, not for everybody. So this is an AML tear. You can see it's very obvious AML tear. And if you freeze, if you see that there is a gap in the AML there, and this is a gap you have to catch. This is a very big tear. You can see the commissures are not split post PBMV, and you should be able to make that. And you put a color there. You can see from the AML tear the mitral regurgitation will come. So this is a severe MR here. And this is what you are supposed to see. So this is what you are supposed to see, that the mitral regurgitation will come from the tear. If it's a commissural, the mitral regurgitation will come from the commissure. So if you see from AML tear, the MR is coming. So this is a commissure. Sometimes MR will come, excessive split of MR will come, or excessive split of medial or lateral commissure, and the MR will come here. The MR when comes from here, this is where you have to alert the surgeon. Most of them will require surgery, probably in hospital or a couple of weeks later. AML tears, you have to be very careful in diagnosing. The common cause, one of the important is subvalvular trapping. When you have a very bad subvalvular fusion, something called balloon impasse will occur. The distant balloon will not open and the proximal balloon will open. So in this situation you have to be very careful, and this is one subset of patients you can land up with a tear, or you may have an inadequate balloon dilatation, and this is the balloon impasse sign. I think his pointers are not okay. So if you see here, the distal balloon is not getting inflated, so there is a severe subvalvular fusion. So if you have this type of inflation, and this is after checking the mobility of the valve, and the distal balloon is not inflating, if the balloon is good intact. So these type of patient, if you try to dilate, you will land in severe mitral regurgitation. Most of the operators yesterday have shown how to see the freedom from the valve. Inflate the distal balloon, push the balloon to apex, get it back, push the balloon to apex, then hook the mitral valve and dilate. If you don't do this step, you will be among the secondary orifice, or you might be according into the cardae or in the subvalvular apparatus, and you can rupture the balloon. Residual ASD we used to keep very commonly in our residency days. In fact, my teachers used to say, tell me what is the cause of ASD in this case. So we used to say, it's patient has a PBMV. So it's not a problem, but some of the patient, the ASD persists, small ASD can persist, that's in older age, and whenever there is a fluoroscopic mitral valve calcification, the ASD will persist. High echocardiographic fixed course, ASD persists. Low cardiac output PBMV, they persist, and very class 4 symptoms, the ASD persists. But this is not much of importance, this is just you can forget. The most important thing is the problem is cardiac tamponade. So how this occurs? So cardiac tamponades can occur if you perforate the aorta, LA roof, and many parts of the LA are extra pericardial. Still, if you are good enough, you can enter the pericardium. So God has given a place for us. Even if you do it, you will not get tamponade, but still you can get a tamponade, because if you go where intrapericardial LA, you can, if you puncture, you will get it. Left atrial free wall, interatrial septum, and this is very important, called as stitch effect, where you enter a pericardial space and come back into LA. So this stitch phenomena, the tamponade will not occur during PBMV. The tamponade will occur after you remove the balloon, because the balloon is acting as a sealing agent when you have done a stitch. So when you finish PBMV, somebody has a tamponade, it indicates it's a stitch. So this is another form of a tamponade. LV free wall rupture is very uncommon now, because we are using Inouye balloon. When people used to use a double belling technique, direct entry into LV free wall is to occur. Pulmonary vein rupture is very, very uncommon. Free wall also sometimes, whenever there is a huge pulmonary artery hypertension, that yesterday Dr. Dash was showing that how you can perforate sometimes the RA free wall in a grossly dilated. So again, going to these details, LA roof puncture can occur if the septal puncture is very high. And yesterday, and again I am repeating the same thing, when Ramaraju also did the case, once you dilate, you constantly check, give puffs of contrast, identify the LA roof, because the needle can go and touch the LA roof, nothing will happen. But if the dilator goes and touch, he'll have a tamponade. So when you're threading the sheath, the dilator has to be fixed. Identify the LA roof. The dilator should be below the LA roof and thread the sheath. Or to prevent that, Dr. Dash has shown another technique, that put the dilator and make sure the dilator doesn't slip back into LA. Put a spring wire. In that way, you can avoid LA roof. And always, patients, whenever you puncture the pericardium, patient will have symptom of a chest pain. Some patient will cough when you do a pericardial puncture. So when you are doing a PBMV, respect the symptoms of the patient. Don't ignore. If they complain of chest pain, if they complain of a cough, alert. Tell your echocardiographer, look for a pericardial effusion. Don't neglect. Don't tell that, because all symptoms you have to be attention during PBMV. So don't. This has happened very times. We had, in fact, there was one patient when Padmanabhan shared with me that he was doing PBM in Srikakulam. So he perforated the pericardium. Patient had a violent cough. So with the violent cough, the whole pericardium, he had a sudden aspiration of air, and patient developed a pneumopericardium. So whole pericardium, in fact, we tried to retrieve the CD from Kim's library. We couldn't get it. I could have shown that pneumopericardium while doing a septal puncture. So whole pericardium is filled with an air. So patient had a cough, violent cough. When she perforated the pericardium, the whole air got aspirated there, and patient went into tamponade. Just left him like that, allowed the air to absorb. Patient did fine, abandoned the PBMV, and then patient was brought back to the lab of a couple of days, and PBMV was done. LA free wall, when you are manipulating the guide wire, can occur. Once you have septal wire, spring wire, the chance of perforation comes down. It is only when you thread the dilator, the chance of perforation is high. Manipulating the Inoue balloon, the perforation will not occur. However, you want to do a reverse loop, you want to vertical, it will not perforate. It is a wire and the dilator which cause perforation. Coming to stitch phenomenon. What is a stitch phenomenon during percutaneous? It's a rare complication when the needle pierces the intrapericardial space from the right atrial side and re-enter the left atrium. The wrong ventry of the LA may be recognized until the sheath is withdrawn and the cardiac tamponade will occur. I'll just show this small video, and this is how the stitch occurs. So what the septal puncture is a very high, and this is the right atrium. You go into the pericardial space, back into the left atrium. So you do the puncture, you are sure that left atrium is there, and you do a balloon mitral valvuloplasty. So this whole thing is sealed while doing balloon. So once you finish, remove everything, patient will go into tamponade. So this is called as a stitch phenomena, and we had a couple of cases where it is quite a dangerous situation. If you don't recognize, the patient go into problem. So this is the patient where we had a stitch, and this is the position of the jalebi wire and trying to enter the mitral wall, and this is the retrograde entry. And so this is, we're checking for the free mobility. You can see that we're pushing the balloon, we can see the flow mobility, then we're withdrawing and then inflating the balloon. And this is the position of the patient, and once we removed everything, patient went into tamponade and patient went into hypotension, brought back, did a pericardial checked the pericardium and drain the pericardial fluid, and this is the aspiration, and patient did well. So very important is recognition of stitch phenomena is very important, and it requires an extra anatomy acumen to diagnose this false track before you insert and withdraw the stitch sheath. Echocardiography should be used liberally to understand, and once you do it, get a tamponade, do a pericardial centrifuge, patient will do fine. Some people try to close with a prolonged keeping the balloon there. Some people try to do an ASD device, this side, that side. But many of these patients really needed a surgery, and then they did well. Luckily, we didn't need a surgery in our patient, but most of the time the stitch, whenever it occurs, they might need a surgery because you are through the RA and LA, and it will be continue to bleed from both the sides. Sometimes you can reverse these patients, unlike in coronary perforation, we don't reverse with a protomy. Here you can reverse the protomy because there is nothing inside, and there is you can reverse and then you can get away with this procedure. So our understandings or misunderstanding, there are 4 different stitches are possible: intraatrial septum, pericardial space, LA roof; right atrium, pericardial space, LA roof; LA pericardial space, extracardiac, re-enter LA; right atrium, intraatrial space, pericardial space, extracardiac, re-enter LA. So these are the various stitch phenomena that can occur, and you have to be aware of this situation whenever you do a percutaneous balloon valvuloplasty. Stroke can occur even with situations of a normal sinus rhythm. You have given a transesophageal echo, you have demonstrated no left atrial appendage clot. So it's very important to recognize how to prevent stroke while doing a PBMV. Again, I keep on telling the same thing which I repeated. Keep the pigtail, don't keep the pigtail in the aorta till you give heparin. Keep it below the diaphragm. Once you give heparin, you can keep, and once you're dilating, don't keep an aorta. You just put it down. Don't keep it in LV. Why you want in LV pigtail? You finish PBMV, go back and measure the hemodynamics. Keep the pigtail below the diaphragm. And in spite of that, sometimes strokes can occur. This I just want to share one of our patient. So is a 33-year-old female, severe mitral stenosis, severe PAH, and we did a balloon. Patient had acute CV on the table, 0/5 power, absolute. She went unconscious. We did a cerebral angio on the table, and it's a complete MCS stem occlusion. So it's a massive stroke. We gave intra-arterial tenecteplase 20 mg. It didn't work out. We called our neurointervention radiologist. He did a mechanical thrombectomy with a stent retriever, 4 into 20 millimeters solitaire, and patient completely recovered on the table. We had difficulty. Patient came for a PBMV. We talked to the finances. I came back. Don't hesitate when I have a complication. Don't hesitate and run off. Don't try to hide. That's very, very important. Don't try to hide. That is the time you have the courage to talk to the patient. After 1 hour, that courage goes off. You try to cover everything. Don't do that. Telling a complication, don't hide. Always tell them, and they'll understand that complication occur. So I came back of the lab. I told you have an option of intra-arterial thrombolysis, some 30,000-40,000 rupees. So I gave, it didn't work. I tell you have to have a stent retriever, there's a cost. They said yes, and patient is fine today. So don't hesitate. Don't you take a decision that what will the family tell? Can they afford or not? That is not none of your business. That is a family business. So this is the same patient. We had difficulty in doing a balloon here again, and this is how we manipulated. Probably we manipulated more. Again, not a direct entry. So, and we did with the jalebi wire because we had difficulty in entering this wall. Of course, this patient didn't have a LA clot, and this is the dilatation. And this is post dilatation. It is a cerebral angiogram. You can see that the total occlusion of the middle cerebral artery here. And this is after intra-arterial thrombolysis. This is after the mechanical retrieving. I can see that all the branches of middle artery are seen here now, and there is no more clot. So sometimes probably we can also do all these things because in our hospital we have a big team of intervention radiologists, and this case we did some 5 years back. Even though patient had a complication of PBMV, this patient sent me four more PBMVs. So what I keep telling young intervention, don't hesitate. I told the patient they had a complication. They paid huge money, stent retriever, intracoronary tenecteplase, but they're very happy. So anybody in their town, they're from Madhya Pradesh. So anybody in town PBMV, they'll get a PBMV and they'll get it done by me. So that's a very important thing for you. Ramaraju was telling that LA spring wire. So sometimes it can break, especially at the welding point where the spring is attached to the stiff part of the wire. So we had this wire breakage exactly. You can see here, that's where the tip is broken here. And we're using a gooseneck snare. So this is mostly because of the reuse of the wire. So when you use a hardware, check your hardware yourself. You know you have a good cath lab technician, good assistant. But when you put a reused hardware, time and time again, we don't check. We just rely on our colleagues. So it happens. It happens still to me. Recently I had a used a G balloon, and balloon was not deflating. The patient can afford anything, but I had my own thoughts. Why should he spend 10,000 rupees extra? But we landed off 1.5 hours of LAD occlusion. Then we bailed him out. So whenever you have to use G hardware, there is no choice. But when you use, check the hardware yourself. You have some patients, check the wire how it is. So we can easily prevent this complication, use of a snare and retrieving of the snare. And then after retrieving, we finish balloon valvuloplasty again. So I keep telling you, you have a complication, don't back out. Just finish a balloon and tell the patient we had some complication. Just put a word that you had some complication, we retrieve. So if you don't tell the patient complication, you will never have courage to speak to the patient, and patient and family, they like that you had a complication, you tell them. Okay. Other important thing is mitral stenosis and coronary disease. That's very, very important. So in India, we know that coronary disease can occur in any age, 30 years, 35 years. I'll share 2 examples of, so especially when you have some doubt, just take a coronary shoot and don't hesitate. It doesn't take much time. So probably otherwise you do a coronary angiogram, at a different time and do a PBMV different, because your problem is giving heparin again. So you can't give heparin and do a PBMV. So this is a 50-year-old female, hypertensive, 8 years. She had mitral stenosis 2015 and she was advised MVR outside hospital. This is again a Madhya Pradesh patient and she didn't undergo. And now she is admitted in March 22 with an end STEMI with recurrent angina. She had a moderate LV dysfunction. She was on dual antiplatelet and the patient came to us. We did an angiogram. And this is how the angiogram shows. This is a CTO of the LAD and you can also see retrograde filling of the RCA both in AP caudal and AP cranial views, and this is a CTO of LAD. And you can see there is a retrograde filling of the RCA and you are seeing both filling of PD and PLVW, and you can see the bifurcation also. And this is a right coronary and you can see the retrograde filling of the LAD and you can see near total occlusion. And at this point of time I was hesitant what to do. Shall I send the patient for the emergency because she continued to have pain? So you have to do on dual antiplatelet a CABG with an MVR. So I went ahead and did angioplasty. What to do, angiogram or angioplasty first? So when I did an angiogram for this patient, I didn't use an heparin. So I did angiogram first because she had end STEMI, elevated biomarkers. So whenever we do angiogram without heparin, the simple thing is all use new sheath, new catheters. Then the thrombus chances will be less. You finish all the injection in less than 3 minutes. So you finish left coronary less than 3 minutes, come out, flush and go back. Finish right coronary less than 3 minutes, come out and flush. So that's why we did angiogram, because we ensure that is end STEMI, she has coronary disease. So we talked to the family. So now which has to be done, coronary or PBMV? So if I want to do coronary, I have to give heparin. Then I can't do PBMV. But patient will not tolerate any intervention coronary disease with this existing mitral stenosis with moderate multi dysfunction. So we went ahead, finished balloon mitral valvuloplasty, and then we stented the RCA. So we told the family everything, that we have done an incomplete devascularization, we have bailed you out. So you will need in future, whenever you have a mitral restenosis, you do a MVR with a CABG at that time. LAD can be grafted at that time. We bailed out the situation. The patient is under follow-up and doing fine. Another example we had recently was a 30-year-old patient who had a mitral stenosis, and he came basically to us with a chest pain and angina. So when we examine 30-year-old fellow, diabetic, chest pain, mitral stenosis, 10% of the patients with mitral stenosis have chest pain, classical teaching because of the PAH, because of the RV ischemia. So we thought it's a mitral stenosis. So I went and did a balloon mitral valvuloplasty. And post-mit balloon patient had a very good result, valve area of 1.5, went home, continued to having chest pain and no RWMI. So this patient, after 1 month, I did an angio again. It showed left main with triple vessel disease. So we told the family that this is 30 years, we can't help, very unusual. So the message here is don't ignore the symptoms again and give respect to them. And this patient underwent a MVR with a CABG because we didn't want him to do a redo surgery for MVR 5 years when mitral restenosis occurs at 10 years later. So we finished MVR with the CABG and the patient is doing fine. So it's importance of symptoms and all these things, coronary disease when you do a PBMV, it's very, very important. The multivariate predictors of mortality or echocardiographics more than 8, increasing age because the wall becomes more bad. Post OMV, post CMV, post PBMV, re-intervention more risky. Whenever you have NIH class 4, I told one situation where patient with class 4, severe PH, severe MS, RV dysfunction, you do balloon. The other complication can occur is after 6-7 the patient will go into hypotension and cardiac arrest. So why? Because we have relieved one stenosis, other stenosis is still there. So you hydrate the patient well, you maintain the preload of these patients because the forward flow has increased, the preload is not there. Fasting patients, be careful. So whenever you are doing NVHA class 4 with a PAH, you have to be very careful. High post-procedural PA pressures, again you have to be careful. Pre-procedure mitral regurgitation more than 2 and 3, they have to be very careful. All these things we have seen all the complications of PBMV. In fact, we had one complications, we were doing PBMV in Kurnool, which I want to share. The septal dilator, the tip of the septal dilator broke, and when we were doing the septal dilatation, so while removing the wire and the dilation, it got embolized to the PA. It is very small tip, we left him off and we did a PBMV and came off. So again, G hardware, so you have to be careful. So all these complications occur, and in fact Padmanabhan was sharing with Ramaraju here in Bolineni only that sometimes one patient was taken for a CMV here in the same hospital, and this was a post OMV patient. No, LA appendage is very small. LA appendage was very small. So it's importance of doing a good echocardiography, and the surgeon said I will do. The surgeon took in for OT. He couldn't put a finger in the LA appendage. So he said I can't do PBMV. I can't do CMV. So patient on ventilator. Patient went into pulmonedema. So the patient was brought back to cath lab because they have done already opening. There is a pneumopericardium there. They did a PBMV and the patient survived. So all these things should be cared up. Everything in PBMV should know, complications, talk to your seniors and learning. So this is a small brief talk on complications. Thank you very much.
Please, sir, please. I request Professor Venkatachalam garu to come over and give a moment to Dr. R.K. Jain. Dr. Venkatachalam is a very good teacher of us and taking very active part in all our state conferences, and he is a favorite teacher for all the postgraduates especially. Yeah, every time he
I came to that Vijayawada. Thank you, sir.
And out of all the, I want to put one more word. Out of all the cardiac interventions, the most gratifying results are only one for pacemakers and second thing is for PBMV. Patient will get immediate and beautiful gratifying results. In my early days, I just want to quote one case. It's around 10:30-11. I went to see one emergency patient in one emergency hospital. While I am returning back, one of the patient attendants who is waiting outside the hospital, he asked me, sir, my sister-in-law got admitted. She said, it's out of hope. We want to take it. Just I am requesting for some concession. Can you put a word? So I went inside and asked the doctor concerned there. They are known to me. Can you give some offer him concession? He said, I asked him what is the case. It is ARD's case, sir. Lungs are very bad, no hopes. Saturations are very much less. They cannot afford. We are shifting. We are discharging Lama. So while coming back, one X-ray was hanging in the lobby. It looks like a clear-cut mitral disease. Ask them, whose X-ray is this? So this is the patient what you are asking for concession. So I got stunned. I went there, asked a later, there is a loud murmur. I have echo machine in my car. I took the machine there and it did echo. It's a tight mitral stenosis, pliable wall. The saturations are around 78 on ventilator. And patient is in very bad shape, cardiogenic shock. So I told the attendants, anyway you are prepared to take. Let us take a chance. So I shifted the patient personally around 11 o'clock in the night and we did an emergency PBMV night around 1:30 and morning 11 o'clock we extubated the patient. That much gratifying the results PBMV will be having.
I wanted to share, I forgot. See, this is a patient who was admitted in KIMS only. This was some 10 years, 15 years back when we were in old block. So patient had a massive empyema, whole of the left lung. So the radiology colleague, we got a CT done, and Ravi Verma was there. So he told some sign is there in the radiology and said he will not survive, he will die. And he had mitral stenosis. So this is again Aragyasri days, and very sick patient, very sick patient. So we told, we always know that if you relieve mitral stenosis, he will do well. Because the low cardiac output, the whole hemodynamics change, so we kept in hospital. We told, those days, KIMS, everything was liberal. We can get antibiotics from outside. We can do what you want. So nowadays it's very difficult to get antibiotics from outside. So you have to use antibiotics what they give in hospital. That's okay. So we treated him for 1 week with a heavy antibiotics and told we'll do PBMV in Aragyasri. And he said, see, you don't have a choice. You either leave, we'll do balloon dilatation. We did PBMV. The patient recovered dramatically, went home. So when they were going home, the attendants told the family that we were coming. This all after 15 days. So the family prepared peenige vastundi. They use the word peenige vastundi. Ready cheddam smashanaki body vastundi, shavam vastundi. It's called in Rayalaseema peenige vastundi. Peenige vastundi. Shavam vastundi. And when they said this fellow life fellow. So that how dramatic PBMV can occur. That fellow is still surviving. And he told me, sir, మేమంతా పీనికి వస్తున్నాం రెడీగా ఉన్నాం శ్మశానం తీసుకోవడానికి వాడు బతికేశాడు. We had another patient when we were in Mahavir, hydropneumothorax with mitral stenosis. So we know that until you remove mitral stenosis, whatever hydropneumothorax, he is not going to go home. So we took him up. 2 days of stabilization, we said we'll do PBMV. And once we did a PBMV, we put a drain. And he is doing fine. So mitral stenosis is one of the intervention procedure where you get fantastic results, very simple procedure. Just you need 2 things, how to do puncture and how to cross. That's it. I think these are 2 stories I wanted to share with PBMV.
A wonderful procedure really. Sir, you said you will share some experience.
Some of you had an experience of removing the unstretched balloon, mitral balloon. Fracture of...
Let me introduce yourself. Okay. He is our teacher, Dr. Vasant Kumar. He is a teacher to all of us. Teacher to the entire faculty who is sitting here. He taught us many things during our Nizam's days. And still, though he is in private practice since long time in Kurnool, still he is a good academician, keep on publishing articles, and he is always updated. And really appreciate his enthusiasm in performing procedures as a single-handed in like what we are in some remote place apart from Hyderabad or Vijayawada. Still he keeps that pace in doing all emergency, and he will be publishing those things. There's a great thing about it. And let us hear some of his experiences in PBM.
Yeah, thank you for your kind words. Have you had any experience of removing the unstretched mitral balloons? See, your LA jalebi wire was not going. Your stretching rod with stillet was also not going into the balloon, and we have to retrieve the balloon outside through the femoral vein. I want all of your experiences. So we had similar something like this. Yesterday, the balloon probably one of the layer got ruptured, and you had a contrast in that. The wire was not going. We had similarly, the stillet was not going, and when we tried to pass the stillet, it punctured. And the next time the LA jalebi wire was also not going into that. Stillet was not going. We tried to retrieve it by the back end of the jalebi wire to come out. Nothing. So we just blindly pulled it out. Nothing happened. So otherwise we wanted to call surgeon. See, when you are alone, your thought process also gets blocked. That's some of the times I take help from Padmanabhan, Jain. I'll send them video that this is the problem I'm encountering. What shall I do? Because when you are alone, when you are in institute, you have safety in a lot of counselors. But you are alone, your thought process gets blocked after some time. So there's a time you should take help from, and some of the times when you are entering the LV with your balloon, you don't know where you are trying actually. And because we are not doing LV angio or right atrial angio or left atrial angio, we don't know where the mitral valve is actually located. That bobbing movement, what all they tell, sometimes it don't happen. So what you have to do, you have to do LV angio again when you are in doubt. See where the mitral valve is opening. That's where it goes in again. So because of our G, we produce lot of complications, but we have to learn from them. If you use probably N material, everything, you will not have many of these complications which you are discussing. In spite of so-called new yesterday, all those wires, the balloons, stillets were not functioning. Maybe we are all getting the inferior quality material. Thank you.
Dear delegates, now we will take a tea break.
There is some delay in the live case. They are changing the case. Meanwhile, I want to present a small case, which is some learning points in that. This case recently we did 1 week back. It's a middle-aged man. Previously, PBMV was done some 10 years back, came with restenosis and exertional breathlessness. And yeah. Just now, during this time gap, we prepared go to echo, present echo. The right mitral stenosis, a semi-playable valve, and the challenge with this case is there is a large left atrium, around 5 plus size, and intra-atrial septum appears to be thick here. Next slide, please. Next slide, please. And it's bulging into RA. Significant bulging of intra-atrial septum into RA. Next slide. This is the TA image.
Can you go to Ramaraju? Can you go back?
Previous slide.
What is that?
This one, actually, this is. Yeah, it is. We crossed it already. Yes, it's. No. Actually, it was not kept in a proper way. This is already. We already crossed it. That's why I skipped it. Next. Next slide, please. Okay. Okay. So actually, we tried to puncture through TE guidance here, but we are unsuccessful because we don't have that much experience in performing. More. Actually, I tried to demonstrate showing a trans-esophageal assisted puncture technique, but we could not do it. Next, that is the needle where you are seeing through the going and encroaching the intra-atrial septum, but it's in an oblique plane. Next slide. It's in oblique plane. This is the standard bicaval view where we can easily identify the fossa ovalis, and you can also judge the antero-superior relationship, superior-inferior relationship of the septum. Next slide. Here you can see the needle going in an oblique direction to the intra-atrial septum. Next slide. We are not perpendicular to the next slide, please. Next slide. Okay. See here, the challenge here is the intra-atrial septum is bulging more into the right atrium. Right atrial space is compromised by intra-atrial septum. Next slide. It's a semi-compliant valve. Next slide. Next slide, please. Just go to PBMV procedure. Next slide, please. Here you can just observe the way the wire is entering the superior vena cava. It's almost at the right atrial lateral margin. It means that there is a huge. Yeah, play this one. There is a huge dilatation of the left atrium encroaching onto the right atrium, and you can see the way the wire is taking a loop in the right atrium here. And the difficulty in negotiating a Mullin's wire also you can see. It has to take a steep curve to enter into the superior vena cava. Next slide. You play this. There is a difficulty in playing there. Slideshow play out videos, and that's we are trying for that. many of the times when the LA is hugely dilated, it will be very difficult to enter superior SVC also. Yeah, play this. You play till the end. Just leave it like that. Next. Yeah. Yeah, we negotiate and we entered and we are coming down from SVC to fossa ovalis. Next slide, please. So you can see a thick septum. And we are puncturing a intraatrial septum. It's a very thick septum. With a jerky movement, it entered into the right atrium, left atrium. And here, yeah, it's a low septal puncture. It's a low septal puncture. And again, in the last yesterday's talk, I spoke to you regarding the staining of the septum. If the septum stains in a vertical direction, it means that your needle is in an oblique direction to the septum. You are dissecting the septum. Whenever you are giving an injection, it should produce a horizontal staining mark. Then only it gives a lot. It means that you will be in an oblique direction. You are dissecting the entire septum. You should not puncture at the, whenever you get a longitudinal staining. You should only get a horizontal staining like this. Then only it means that your needle is perpendicular to the septum. Next slide. So it's a low puncture. It's very difficult to make a precise puncture whenever there is a huge left atrial dilatation, because you cannot really be sure whether you are puncturing through the fossa ovalis or something like that, because LA will be huge and to precisely puncture it's very difficult. Here the puncture we got is a very low puncture. Next slide. You can see in the next. Is a huge left atrium. Next one. The puncture is almost above the mitral wall level. Can you see the tip? The sheath is almost above the mitral wall, very low puncture. You can see the mitral wall. It is just above the mitral wall level. So the challenge now is if you do such a low puncture, it will be very difficult to cross the mitral wall. Next. So as soon as we tried to pass the spring wire, it entered directly into the left ventricle. So we thought we can take the advantage of this and we can directly enter the left atrium. That's what we are trying to do is jalebi wire entered the left LV and we are trying to push the balloon directly into the LV. But the wire did not give support because it's a low puncture, it came out. So we have to search for other alternatives to enter the mitral wall. The only other alternative is we have to, whenever you are doing a low atrial puncture, LA wire, we have to reshape the wire. You have to give a wide angle. Suppose you did a high septal puncture, you have to give a very steep angle. If you are doing a very low atrial puncture, you have to give a very wide angle. So we changed the shape of the LA wire and we tried to enter the mitral wall, but we are not successful. Still it. Yeah, yes, sir. She's. I'll show you, sir. In one more presentation, it's there. I'll show you. So we took the alternative loop. I just want to demonstrate the alternative loop here. The advantage of this, especially when doing a low atrial punctures and especially whenever there is a large left atrial size, it is very difficult to cross the mitral wall. Dr. Padmanabhan taught us how to do an alternative loop. always whenever you are doing an alternate loop, you keep the balloon at the mouth of the one of the pulmonary veins, inflate the distal balloon so that it will give you an anchoring to the distal balloon. Then you take the loop in the LA, or you hit the LA roof, inflate the distal balloon and take a curve so that it will form a loop there. There are two techniques. One is a hairpin loop and this is an alternate loop. Here you can see in the reverse loop we are trying to enter into the mitral wall here. Next slide. So we entered through the reverse loop into the LV and we inflated the distal balloon, and once you inflated the distal balloon, we have to unloop the balloon, unloop the balloon. With this loop, this is a disadvantage loop. We have to take this advantage only while crossing the mitral wall. Once you enter the mitral wall, we have to unloop this again to check the stable position. We are trying to unloop the balloon, but always keep the distal balloon inflated while doing all these maneuvers, because the balloon may easily slip out. Yeah, it's a semi-pliable wall, and you can see the way the balloon is getting inflated. Lateral commissure yielded very well, and the medial commissure you can see it's not yielded, and you can see the way the balloon is inflating. Lateral commissure gave away, but medial commissure did not. But still, after the procedure, valve yielded very well. Pressures came down significantly. So I just want to share the experience of doing a reverse loop in this case. I think it's okay. Huh? One more case, I want to show you one slide how to make a loop bend here. A transeptal puncture. Close this. Transeptal puncture. Last week. This is the way how you alter the shape of the LA wire. Suppose it all depends upon the size of LA and the site of the puncture, whether it's high or low. If you are doing a high puncture, you make a more steep curve of the LA wire, and if you are doing a low puncture, you have to make it more less steeper so that it will directly try to fall into the mitral wall. Check whether live case is ready or not. This is the low puncture, sir. We have to make a wide curve. This is for the low curve. This is for the high curve. High puncture. What? High puncture. Yeah. Live is ready. Oh, we'll shift to live case then. I request Dr. Chalam Garu and Dr. Chaudhary to be the moderators for this session. Huh? Female breast cover.
Hello. Am I audible, sir?
Yes, you are audible.
Sir, now we are going to the third live case of today's session, sir. Patient clinical details. Patient is a 48-year-old female presented with exertional breathlessness and palpitation for the past 6 months. Patient is a sinus student, function class 2, sir. On 2-day echocardiographic evaluation, patient has severe chronic rheumatic heart disease with severe mitral stenosis, with mild mitral regurgitation, with mild TR with severe pulmonary hypertension. Our colleague, our 2D echocardiography data set, LA is grossly dilated with 4.8 centimeters with mitral valve area with diameter around 1.0 centimeters square with mitral valve gradients around 26 by 15 mm of HSI with severe pulmonary artery hypertension. And now we will show you some 2D echocardiography images. The leaflet tips are calcified.
Chaudhary, I am audible there?
Yeah, you're audible, sir.
So here Dr. Padmanabhan is there with me. So it is a rare opportunity for me to do a procedure with Padmanabhan sir after quite long time. We did mostly angios and PTCs in the jumps, and now we are doing. So having a doctor like Padmanabhan sir, great thing. So we are going ahead with the procedure. One case we are done. Now we are passing the wire.
Sir, any tips when you face any difficulty in passing this wire to the innominate vein?
It went straight away.
In difficult situations, particularly when LA is grossly dilated, when it's pushed towards the RA side, if you keep the...
Sometimes it will be difficult. In those cases, what you have to do is you have to go to the lateral view.
Okay.
Then you have to manipulate the wire. We do sometimes like that.
No. Sometimes entering the SVC itself, it will be difficult. You will be entering the RA, and after that entering the SVC will be then how to tackle that? One is asking that patient to take breath and then it will go. RCA catheter. And one more thing is, you face the sheath direction towards the RA, towards the right margin, then it will go easily. And still, if it is difficult, bring down a little bit below the diaphragm and then try to go again. The orientation, it has to find the proper orientation.
If there is a difficulty in passing the LA wire, one technique is you can SVC wire, Mullin sheath, you can do it in a lateral view. You face it more posteriorly and it will pass. It will definitely it will go through lateral if you change the direction of the catheter.
To summarize, in AP view, that should face towards the RA side, and in lateral view it should face posteriorly to make the entry into SVC easy.
Small announcement. who are interested to go to 3D echo, you can go there. Echo machine technicians are ready.
Padmanabhan, how comfortable are you doing septal puncture in AP view? I have not done. Okay. Not comfortable. Good. But I believe you went to Innove also, no, to learn it. So. So, I'll just share a small story. So when I was a DM student, Padmana was a consultant. So on that day, I had a Katla posting. So Innove came to Hyderabad to Usmania to show how to do PBMV. So I said, I'll also come. So Padmanabhan said, first to compress the groin. Innove, you can meet him later. So after 20 years, again I met him in NIC, Calcutta.
You can see that vertical staining of the staining. It means that the needle is in oblique direction to the septum. It is dissecting the septum.
I think Padmanabhan, we are not used to this sheath, this abort sheath, and we are all used to Medtronic sheath. That's why we have a lot of puncture problems. So, so we are all used to Medtronic set. So, no, it's not available now in the market.
Most of the EP people, they do in right array overview. And see, the normal septum is different from the left atrial septum, septum in mitral stenosis. The orientation is different. They feel confident in array overview.
Why we are facing so much problem when we try to learn it and do it under TE? I face more problem than when doing
We are not
blindly.
used. See, it is as simple as ultrasound guided femoral artery puncture. Can you do it? Difficult. That's what I'm telling. So we learned doing a blind puncture. Now You need two-hand coordination. You need ultrasound with one hand. You have to see the not fluoro. You have to see the screen, and then you have to puncture. I feel I'm not able to do it. I tried many times, but the younger generation now who are there, they have to do it. They have to learn. They have to learn ultrasound guided punctures. And I tried my best. I can't do it. Many times I tried. We have now dedicated vascular probe in our cath lab. So we tell all our juniors, you please do it. Because necklines also, Ravi Teja is here. He will not do ultrasound guided. All my necklines he put, any procedure. But when other the juniors are there, they are all doing ultrasound guided neckline puncture also. It's very important. That's we're not using. Yeah.
And even clinical also.
I'm not able to unlearn and relearn.
Kumar, you are not audible.
Lung, we are not using it.
Yeah, that's what we are also seeing.
See, the problem, what is happening is the curve in the broken burrow needle is much more than what we use.
What did you say, Padmanabhan? Broken? Low puncture, yes. And even that Mullin sheath is not turning. It's more vertical. It's more vertical. Even Mullin sheath I was not comfortable. In fact, that's why I told Raja to keep separate 4 Medtronic sheath and needles for me. So he has kept stock of that in Kim's.
There was a serious shortage of the material, sir, from the last 3 months. Probably that helped us to conduct this workshop.
On a wire, can this perforate the roof of the atrium?
No.
See, they say don't go beyond.
No, nothing. It will never, nothing. On wire, nothing will happen. It's a bare dilator which causes. It's a bare dilator. Padmanabhan, they have already given heparin for information. Here they give before puncture 2.5. That's what yesterday they told me. Funny be true. No, they give 2.5 before puncture, 2.5 after puncture. On operator. It's a local guidelines. What are you going to do? We have to follow the local guidelines.
70 units, 100 units per kg body weight. Some people give 70 kg.
All these PBMV patients are all underweight. I think you can just go with 5,000 as routine. I think 5,000 should be the minimum. It should not be less because you are working on the left side.
Any sedation you people are giving regularly, fentanyl or something? Septal dilatation. Okay. Not routine.
No, Ravi, Srihasan, it's not the pain is not at the septum. The pain is always at the groin. It's a groin. So you give good local and there's no septal dilatation doesn't cause pain. No. Very unlikely. I don't know. Dr. Dash is there? He's gone. He left. Can you go for, yeah, this is a very nice tracing. In fact, they show in 40 scales. Yeah, 40. Yeah, yeah, it's very nice gradient. How many of you know that planimetry of mitral wall? So when who asked? Dash asked. So we all of us did calculate the mitral wall area. So you all have automatic mitral wall areas and gradients. So we, as a punishment, no, whoever cath lab resident was not working doing DM. So they used to give 100 PBMV tracing. So we have to do with a planimeter. Manually you have to calculate the area and calculate the valve area. Mitral wall area. Garland's formula we used to use. With planimetry area, we have to trace the gradient and get the mean gradient and calculate the valve area. With the magnifier, we have to trace it. I don't know, I don't know, it will be there in Nizam still. It will, but hopefully it is not. It's probably you have to keep. So we all used to do that calculation of mitral wall area. Very low.
Probably you have not, never seen. Sir, Sir, in your pediatric cardiology department, are they doing routine cath studies, sir, as we used to do in shunt calculations, cath calculations?
They do only whenever there is a PAH, when they are not sure. Otherwise, they are not doing routine caths. In fact, we all knew that most of the caths we did in those days were not necessary. So, but right now they do only when there is a PAH, when they are doubtful whether you have to do something, they are not able to sure. Because we have a very huge pediatric department and they do very good number of variety of pediatric surgeries. Any pediatric surgery they do. So there we hardly see them doing a routine cath. No.
See, you were doing right heart regularly when you were doing DM?
Yeah.
Yes.
I don't think now they are doing regular right heart caths.
We used to do right heart.
Yeah, that's the first thing.
Even the normal coronaries they used to make us. Then for every PTCA we used to place that.
Even endoscopies.
Yeah.
Padmanabhan, you have to do reverse loop.
That time they used to give lot of heparin and the groin complications were too bad.
పోదు స్పేస్ లేదు అది అక్కడ పట్టుకుంటుంది సెప్టమ్ దగ్గర పట్టుకుంటుంది Padmanabhan, please step all the steps for reverse loop, please. And take it up. Yeah. It's a very cumbersome procedure. I don't like the twisting of the balloon.
Have you perforated the balloon with the stillet? Any of you?
Perforated the balloon? Yeah, that.
Putting a stillet.
Yeah, it can happen.
Your stillet. No, it happens. Where are the situations where you use a counterclockwise rotations? Some of seniors can tell that. In most of the times in cardiac catheterization we use clockwise rotations. What are the situations where you use a counterclock movement?
RV to P entry, we have to use a counterclockwise rotation, and even in keeping a temporary pacemakers also at times to reach the RV apex.
Mitral valve entry is a counterclockwise.
One which we routinely use is to engage the carotids and others, and when we are going to the subclavian and pulling back on counterclockwise the rotation in the catheter, and engaging the carotids etc. with other catheters like Siemens catheter etc. The pullback and counterclockwise rotation really helps.
They say to enter the non-coronary cusp, the sinus, in the aorta for putting the
Pictile in the non-coronary. So because it's important to keep the pictile in the non-coronary sinus, one technique which Dr. Vasant Kumar sir is suggesting is to give a counterclockwise rotation and pushing it down.
And some people actually give the injection to demonstrate that in the lowest sinus, initial days of training.
Padmavan sir, what is your experience in direct LV entry, and what are the hardware you recommend to do LV entry?
See, low purchase actually it is very good. Best will be to actually with mitral now. We can take actually arrow balloon flotation.
Balloon okay.
That crosses easily. Arrow injection we take some brain harmony. And then generally we put that.
So what you have to do, you put a Mullin sheath. In the Mullin sheath, you put a wedge catheter. Allow the wedge catheter to go into the LV, and then thread the Mullin sheath through on the wedge catheter into LV. Then put a spring wire, and then finish the procedure. Otherwise, you have shown one case in the last presentation. In a low puncture, sometimes it will go, but it's not easy to go to the spring wire. So, balloon flotation catheter seeks, because it is a flotation, it has to go into outside. So that's how it goes. We have done couple of cases that balloon and then pulling the Mullin sheath and LA wire. What you should understand, if you want to put only wedge catheter and then remove keep a LA, it's difficult. So you have to put a Mullins and then go and then remove the wedge catheter and then do the procedure.
The initial days of balloon dilatation, they used to put a LV 2 wires, double balloon technique, with a wire curves in the apex, with 038, something like suprastiff amplitude wire. But I saw one case of apical perforation during those procedures.
That's why now I said in my talk also, LV perforation after Innove, it's rare, very rare, LV. But when double balloon technique was used, because you used two stiff wires in LV, so the tip of the wire can perforate.
Though it has a J-shaped.
J-shaped, yeah. Are you doing, can you show fluoroscopy please?
Some people manipulate that the lower end of the what he is doing.
Yeah, I think he's not doing reverse, he's trying that.
Sometimes your mind will not be sufficient. Then you don't get.
We had one case I just want to share. I was working in Medicity. So Padma Kumar, who had a very good experience in PBMV, so we started a case, very severe, 0.3, 0.4 critical mitral stenosis, very thin lady, BMI of 16. So we started around 3 p.m. So we tried to cross, till 7 p.m. we couldn't cross, 7 p.m. So I told Padma Kumar what to do, and she was very critical MS with a severe PH, and her body weight is some 25 kilos. So then he said, we'll call Shailendra Singh. So we called Shailendra Singh. He came at 8 in the night, and he did the technique of putting an arrow wedge catheter with a Mullin sheath, and on a jalebi wire we dilate the balloon. And after that, this is in 1999, and she did extremely well for 10 years, and she was a widow, only one daughter. And then we did MVR again. She had again restenosis. She went around all the hospitals in Bangalore. Nobody did MVR. She came back to us. We did MVR, and now she is still there fine. So we took almost 9 hours on that day. 9 hours. PBMV, 9 hours. And that works. And we see, other thing is, when you're not able to do, call the expert. And Shailendra Singh came from home. And if he took 1 hour, 1.5 hours, but he had the technique of crossing. This I'm talking about 1999. And she's fine till now.
That's why your senior is the most important person.
Yeah.
Unlike other fields.
Yeah.
Senior is the most important.
Yeah.
person.
Medicine always the person who is in.
Stumbling block many times.
Yeah, and you should not hesitate to call them whenever you want to bail out. I think he's in RV, no, Padmanabhan now? No, but now I think your jalebi is in RV, I feel. Yeah, you're coming out. Oh, you're doing another puncture, okay.
Sir Jain sir, in your slides you have mentioned about some cogwheel resistance while withdrawing the balloon from LV apex to the mitral valve level. One should observe for cogwheel resistance you mentioned. Can you elaborate, sir?
Again, same way, that the freedom of the balloon to go to the apex and come back. There is a resistance. If you are not able to do it, that means you are in the subvalvular, you are in the severe chordae or subvalvular, you are stuck in the subvalvular apparatus. Don't do that. I told Dr. Ramaraju, you plan another next PBMV with showing all other modalities how to do PBMV. There is one technique by double balloon technique, one technique by Joseph balloon technique, which is very economical. The Joseph balloon can be used, I think, 5 to 10 times. It's not be a problem. It's only 20,000 rupees. Yeah, it's 20,000 rupees only. It's not very expensive. But there is a different technique how to cross a wall in that. And then there is another double balloon technique. And the third technique by Greece doctor, he does from the left ventricle. He goes retrograde. From the aorta, LV, then he put it a balloon and does it. I don't know, probably, I don't know, it's called Stephanidis technique. So I haven't seen anybody, but then next workshop I think he can plan to call double balloon. Shailendra Singh will do double balloon, or Padma Kumar also might do double balloon. And Joseph, we can call George Joseph to do a single balloon with his own balloon. And then Stephanidis, somebody is still doing in Europe, you can call him for doing retrograde PBMV. It will be very good demonstration of still, because you have so much of endemic area, still probably you can try to improvise on that. Actually I forgot, I should have told you, you would have planned it. 2 people you could have easily called for double balloon and single balloon. Because you have volumes here, finance is an issue, and then you start upgrading your skill to Joseph balloon, it will be very good, I am telling you. Yeah, you can call him. Because economics will work for you then.
Meanwhile, any of the junior colleagues, they can just raise their points, or you can share your experience, or give some suggestions or whatever, because they are trying to read puncture once again. Anyone?
If anyone wants to make a comment, please raise hands. No.
Sir, in case of low puncture, can we try by passing the thermo wire, sir, through the mitral wall? In a thermo wire, instead of LA wire, can we pass the thermo wire and place it in aorta? Even if we place in aorta also, the manipulation is difficult.
Sir, excuse me. Sir, excuse me.
Yeah. Hello.
Sir, in lateral wheel, how much distance below we should come from that NCC aortic route, sir, for that mulling?
See, in the lateral view, you will keep a catheter in the pigtail catheter in the non-coronary sinus, and you will draw an oblique line from the root of the aorta to the posterior cardiac margin at the level of the diaphragm. Fossa ovalis almost lies at the junction of the mid and lower one third of the oblique line. So you have to take this as an arbitrary line from the base of the aorta to the posterior margin of the posterior cardiac margin at the level of the diaphragm. At the junction of mid to lower one third, you can attempt, and always see that the needle faces posteriorly always, because the interictal septum will be fossa ovalis will be the most posterior portion, and you have to see that the needle is facing posteriorly. So whenever there is a difficulty in crossing, always don't waste time, go for another puncture, it's more easy. With the response we got in the present with the session, I would like to have some suggestions to continue this program for the training of the juniors in the coming years, and I want any juniors to give their suggestions regarding this, and later we will take the help of the seniors, because after the live case we will be closing the session and we will be hands-on experience. I think who are here can be in the cath labs, directly witness. We have some 6-7 cases left behind in both cath labs. You can directly witness to see the cases, and also we have a 3D demonstration, 3D commission demonstration there, and one engineer is also there to help us till 1 o'clock. 102, it's a ground level 102, 3D commission is there. If anyone is interested to learn, he will demonstrate you how to see. We can keep some cases and learn that. Sir, you are not that audible, sir.
No, sir is saying that we are quite superior when compared to the previous one.
Yeah. The way the LA wire entered, it shows a good.
We went very close to the pigtail.
Yes.
If you are observed in the lateral view.
Who is the other fortunate doctor who is working with Dr. Kumar? I see. I see. Huh? Feedback forms are provided in the handbags which were given to you. Kindly fill in the feedback forms and submit in the help desk which is outside the conference hall. also looks like low puncture, but still it's better than heel cross. Yeah, they crossed. Yeah, you can see the movement there. It's easily freely mobile from apex to the mitral wall. You should doubly check well before inflating, because in the earlier frame it got stuck in the sub wall and it's not, balloon movement is not that there. Yeah. Can you replay the Kumar? Can you ask them to replay the fluoro?
Other important thing, the person whoever is giving inflation, he feels a snap of the when it breaks. Second thing, and if you see the inflation, you can see the snap there also. Here the lateral commissure open. You should get that. You should do a Valsalva. If you don't do it, you are not going to get that snap. Yeah, you are not going to get the snap. That Valsalva should be there. In fact, in coronaries also people are not injecting properly. That's the biggest problem with the new generation cardiologists. They're giving phasic injection in coronary. So you can't, sometimes we think it's a thrombus, sometimes we're not able to assess the lesions. Streaming. So you have to give the 10 cc, you give 5 cc at a constant pressure. Then you'll get a good opacification of the coronary. So many times we get angios, we feel that the quality of angio is not, just because the injections are poor. The cath lab is good. The injections are not good.
And some seniors like Dr. Raghav Sharma says he doesn't believe in junior giving injection. He gives himself. When he is doing surgery, he says air. Injecting air is also one common mistake.
Okay, she has gone AF.
So when a patient is having post-PBMV immediate procedure AF, what is the strategy, Rajendra?
Yeah, you just wait. Probably sometimes take a pigtail in LV and just stimulate, probably induce an ectopic. It will convert. But again, we are talking about a mitral stenosis AF, nothing will work, because it's going to be probably this patient already was going into intermittent AF, and now because of your manipulation, it has gone to AF in the LA. So just try to, don't try to do anything, just leave her off. She will convert, but make sure that she gets anticoagulation. Because she is already, because you set me, there is a huge LA here, and she is going to be going to intermittent AF. And this is a patient where in follow-up next to 2-3 years, he has mild MS, she will throw embolus in the brain or in the peripheral, and she is going to lose.
LV and LA, what is there? And increase the speed to 100.
In-house.
What is the speed?
The base study.
Yeah, left main. So now you can see. Ramaraju?
Yeah. No, hemodynamics we didn't see. We are able to see only a still screen. Hemodynamics we couldn't see. No. We are only able to see the fluoro, not the hemodynamics. Yes, now we are able to see. MR problem is not there. They have shown echo. No, hemodynamics. Yeah, now we are able to see the echo. No MR. Trivial.
There is some eccentric MR is there. Very, very small.
Kumar, Ramaraju could count 8 RBCs which causing MR. Yeah, 8. Yeah, you can see now 9. No, it's 9. Sorry, it's 9. It's a very trivial MR, so don't worry. I think. I don't know what Padmanabhan. What do you think?
It's a trivial MR.
Why we are worried? Because patient is having tachycardia. Okay, so we are worried. You have to carefully look. That's very important. Leaflet or commissural. You have to be very sure that what's happening there. No, coming out correct. Why is so much? The heart rate is so high still. AF, okay.
Kumar sir, after completion of the cases, please come to the cath lab. All of you will have a closing here. Conference hall. We'll have a closing meeting, and then we'll start hands-on training for the left other cases. మీరు అందరూ వెళ్ళిపోయినారు, మా పాటలు మేము పడతాం.
డిస్ట్రిక్ట్ రాజమండ్రి డిస్ట్రిక్ట్ రాజమహేంద్రవరం డిస్ట్రిక్ట్ కూడా డిస్ట్రిక్ట్ ఇటు గోదావరి కోనసీమ డిస్ట్రిక్ట్ కాకినాడ డిస్ట్రిక్ట్ గోదావరి 4 డిస్ట్రిక్ట్ అదే కోనసీమ డిస్ట్రిక్ట్ కూడా కోనసీమ డిస్ట్రిక్ట్ కాకినాడ డిస్ట్రిక్ట్ మన్యం డిస్ట్రిక్ట్ అయిపోయింది కేసు కేసు అయిపోయిన అందరూ పైకి వచ్చి కేసు
క్యాథెటర్స్ బాగా మాట్లాడుతుంది ఫస్టే ఒక 10 క్యాథెటర్స్ సమ్మిట్ ఇన్వెస్ట్మెంట్ బాగుంది చాలా అడ్వాంటేజ్ వితౌట్ క్రెడిట్ అంటే మాకు హైదరాబాద్లో నోబడి దాన్ని మాకు ఈహెచ్ఎస్ అనేది క్యాష్ నో క్రెడిట్ అని అడ్వాంటేజ్ ఈహెచ్ఎస్లో పిఎఫ్ రాదు పిఎఫ్ చాలా తక్కువ పిఎఫ్ కనీసం కాస్ట్ వస్తూ ఉంటుంది.
With this, we conclude the scientific sessions of the meeting, and from afternoon we have some 6-7 cases for hands-on training, and those people who are interested are already registered, and others can come and witness. And we have 2 cath labs, and also there is a 3D demonstration machine here, and application engineer is also here. If you have any interest, you can learn 3D code there. And with this, after lunch, we'll conclude the session here in the conference hall. And I sincerely thank for all of you for making this a workshop a grand success. And your presence and attendance is really gives us a good encouragement to do such programs. And earlier we did one workshop on aged device closures. I think we can do one such thing also to train the juniors. And with the present encouragement, we try to conduct it in a regular basis to give training for the juniors on PBMVs. And I request, I sincerely thank all my seniors and my teachers, Dr. Vasant Kumar, Dr. Padnaban, Dr. Rajendra, Dr. Kumar, Dr. Raghu, Dr. Sujata, Dr. Dash, especially Professor Dash. He actually, when we invited him, we doesn't know much of his profile. We know him as a teacher, but when we invited him, he said, I'm not free during those days. But somehow, probably because of the passion for him, we have seen his passion to do PBMVs. Immediately, the next day he called, said, I'll be there here for 2 days. To our surprise, he did more than 20,000 valvuloplasties in his entire career. That's a great number, and we could see how fast he is doing the procedures at this age. So, definitely thank you all, sir, because of your expertise and techniques. We learnt a lot of things from you in these 2 days, and definitely I think this program will be is of much boon to the junior cardiologists. I think so, and I need feedback and your opinion regarding this program to improve further, and how to improve and how to organize the things much more in a much more better way. I request Dr. Vasant Kumar sir first to come out to the dais and give some suggestions, and I request all the seniors to give some suggestions, and later also juniors also you can share your experience here. Please, sir.
I think we should all thank Ramaraju for a very warm welcome for all of us here, and nostalgic moments and a lot of learning. See, every time you attend one workshop, and the first 1 week we should go and try to do one case. Try to do. Otherwise, we will lose touch. Once, if it is 2-3 weeks away, we will lose our touch. Then the same enthusiasm will not stay with us. And we should not expect any immediate returns in the form of finances. Kim's people are doing their balloons. The consultants in Hyderabad, they are buying their own balloons and doing, because to keep in touch with the technique. Otherwise, if you depend on administrators, okay, that is 60,000 almost. So when you want to learn, it doesn't come cheap. Luckily, he has arranged everything free. Otherwise, for the same course, all of you would have to spend 50,000 rupees, nearly for everything he has arranged. So it's a good experience, and I think we should feel free to ask questions. However simple the doubt may look, like entering the groin, entering the atrial septum, locking, unlocking the gold and the silver, because those are the steps where we make a lot of mistakes and land in problems. And at the end, I want to congratulate Ramaraju, Bhaskarrao sir, and entire Kim staff for making us really feel special. Thank you.
Any suggestions for next?
No, the suggestions, as Dr. R.K. Jain said, yeah, nothing more.
Anyway, as an extension, take care, sir. As an extension to Dr. Vasant Kumar's words, in the last EuroPCR meet, when I went there, I had an opportunity to attend some sessions on pulmonary thromboembolism. I got really fascinated. So, lucky, to my luck, on the third day after coming here, we had a massive pulmonary thromboembolism patient. So immediately we tried to push, we got the penumbra, everything in a 4 or 5 hours time. So patient was in desaturated state, tachypneic, saturations are around 88, 90 like that, PO2s are around 60. So we took him to the cath. This is a first experience for also. So we took the challenge, took him to the cath lab, severe RO dysfunction. So when we did a pulmonary angio, entire left pulmonary artery is knocked. So we did a pulmonary aspiration through penumbra. We used penumbra. We aspirated entire thrombus in pulmonary artery, and to our surprise, on table saturations got improved. Hemodynamic, we could just stop the inotropes. Pressures improved. Patient became well, and by we shifted immediately to the hospital. We discharged on third day. He came for the first follow-up, and we repeated the echo. Entire echo is normal. RAR disappeared now. It's the wonderful experience. So whenever you see a case and learn a case, try to do it as early as possible. Once you do it as early as possible, you will not forget the techniques. Thank you. R.K. Jain sir.
Excellent workshop. I was very thrilled. So some suggestion to do more interactive session is to get a heart specimen from medical college, get 1 or 2 specimens, and you can show in that how putting a Mullin sheath, how from SVC you come back, how you get that first SVC RA junction and in aorta, and then how the Mullin sheath falls into the fossa valleys. So I think you can 2-3 specimens you can get 1 hour session every day. That's one suggestion. Second suggestion I told him is to get some PBMV procedures with a Joseph balloon. That's a single balloon technique, how to cross. Because again, because of shortage of all this material, the problems with the spring wire, the problems with the LA stillet, reuse of the Acura balloon, all this can be prevented. But there is some learning curve there. So next probably workshop we should plan to get doing PBMV by other method, single balloon technique, and the age old double balloon technique. Some experts are still there, so you can call them and show them. Then the last technique is Stephanie's technique. So we go retrograde from aorta, put a balloon and then cross and do it. So probably my suggestion is next workshop he can probably take it to this higher level. So people will be more energetic to come and attend and learn all these techniques. That's what I suggested, because I don't know next year will he have 60 PBMV cases. So that's a question. So if he can collect again and plan this, it will be good for the demonstration, and he himself can probably shift slowly towards Joseph Bullis to reduce the cost, and probably all the people in this area, you can reduce your cost and increase whatever the profits to the hospital or to the organization. This is my suggestion, but very well organized, excellent, and it's good he is doing this. It's painful whenever you want to do a workshop. It's a pain leaving the family alone and the family comforts, spending time with the family and a lot of other works, but then once you finish you feel very great. So it's definitely painful, but the results will be very good. Academically you also learn, you read, you understand that where all. So when I try to do slides and I thought I made a mistake, I didn't have that slide, I didn't have that CD. So at least you next time when somebody hospital people sell, you throw all your CDs. No, don't keep. Then you archive all the CDs. That's very important. Then you learn that we did the case, I am not able to demonstrate that case in the workshop. So that's another thing you learn when you do workshop like this. So when you go back, probably when you are in a better position to workshop, always do this. So you will be a better person next day. That's what I learned when I did my first transradial workshop, 2-3 workshops I did. Then I know how to do it. Then that's how we learn. That's very important. Thank you very much.
Thank you, sir. Dr. Padmanabhan, sir. Dr. Padmanabhan, sir, is a mentor for all, and through him, all of us learned PBM techniques.
Probably a day has come, then now I have to relearn from Ramaraju. Anyway, it was very well organized. I really appreciate the initiative taken by Ramaraju. He is always up to something. It's good, nice to see young cardiologists, so many people attending, because for them it is almost like not a common procedure. They may be experts in coronary interventions, but now this frequency of this mitral valvuloplasty has come down. And anyway, it's very important all of these people are aware of the septal puncture. That is most important, because it will be useful for other interventions as well. And one thing what I see is in the future, maybe most of the people will be doing septal punctures through TE imaging. That will be the thing, because with the 3D you can get a very good orientation. You can be much more precise. And maybe another thing is radio frequency instead of a broken barrel needle. So that once it is under guidance, it becomes easier to do a Bellis needle. And
Next time we can ask Agri to do some radio frequency.
I know septal puncture shade regular is. I have not seen anybody doing, but recently one for Dr. R.K. Jain's case of TMVR, they did a cautery assisted septal puncture. Same needle, you can use a cautery, so it becomes very easier. So I definitely feel that the complication rate, especially of perforations, will come down if you use it. Posteriorly, cautery, that will be easier. It will be cost effective for us rather than the radio frequency. Yeah. Okay. Thank you.
Thank you, sir. Dr. Kumar. Raghu is not here. Dr. Srinivas Chaudhary. Have lunch. Yeah. No.
It's a very well organized session, and Dr. Ramaraju is known for spreading knowledge and encouraging the juniors to learn. It is there from in his genes from the days of NIMSET exam. His notes are very popular in those days, and I don't know, some of you might have read his notes even few years ago. So I really appreciate him for organizing this conference very well, and his hospitality is also well known, and we have learned many things from seniors like Dr. Padmanabhan sir, Vasant Kumar sir and Rajendra Kumar Jain sir, they are all very good teachers. So we are very fortunate to have all of them here. Thank you.
డాక్టర్ చలం సార్ ప్లీజ్ మీరు చెప్పకపోతే అసలు డిసప్పాయింట్ అవుతారు పిల్లలందరూ. రండి సార్ రండి, అట్లీస్ట్ ఫోటో మీతో దిగే అదృష్టం ఇవ్వండి మాకు సార్ వాళ్ళతో. రండి ఫోటోకి రండి ప్లీజ్ రండి సార్ ప్లీజ్. దే విల్ గోయింగ్ చదువు ఫోటోకి అందరూ వచ్చేయండి ప్లీజ్ జాయిన్ ద గ్రూప్ ఫోటో.
సెంటర్లో పెట్టి బ్యాక్ వెళ్ళి పర్లేదు నువ్వు వెళ్ళు బ్యాక్ వెళ్ళి పక్కన సెంటర్ అవుతుంది. మీరు పైకి వెళ్ళండి. చెప్పరా నాని ప్యాన్ క్లోజ్కి వెళ్ళి ప్యాన్ చేసుకుని రైట్ ప్యాన్ అవుతుంది సార్ కూర్చోండి. మొత్తం 40 GB దాకా వస్తుంది డేటా. తీసుకున్నాం డేటా చేసి అవ్వట్లేదు ఎక్స్పాండ్
ఆడియో తీసుకోవాలా ఆడియో కావాలి మైక్ మైక్ ఇదిగో నాని ఇదిగో అదే ఆ మైక్ హార్డ్లెస్ మైక్ మైక్ అంటే సపరేట్ సింపుల్ కావాలి మైక్ మైకే ఉండదు
మైక్ వద్దు
మైక్ కావాలి సార్ ఆడియో కావాలి కాదు సార్ చేయాలి చెప్పాలి సార్ ఫీడ్బ్యాక్ కావాలి సార్ కొంతమందికి డాడీ సార్ అన్ని స్ట్రీమ్ ఆపమంటారు లేదు 3 లింకులు ఇచ్చాను బ్రో చెప్తా కార్లో వెళ్తాం మనం పెట్టుకుందాం తర్వాత కావాల్సినప్పుడు